Chapter. All right, so it is June 8th, 2021. We are in officially Therex class, but we're going to combine some kinesiology with the Therex. One of the reasons I'm in a t-shirt is because I'm going to be moving around quite a bit, and it's not as easy to move around in a polo as it is a t-shirt and shorts. So we're going to be demonstrating and practicing doing some kind of instructional exercises on me and using me as the guinea pig. That's the plan for later. And also going over some soap notes, like I said, and just finalizing the the manual testing the hip. So let's first, I want to step back to what we talked about yesterday. And let me bring up my little whiteboard here because I like having my whiteboard up. Here's my whiteboard. Let's bring me into maximum view and get my little chat box up. I want that over here. This over here. There we go. Chat box. There's my chat box, and there's my beautiful participants. So let's first of all think about when we're doing manual muscle testing, or when we're doing goniometry, or when we're doing anything like that. What are the primary motions we're going to What are the primary motions we're going to be testing for goniometry and manual muscle testing of the hip?
Flexion extension.
Flexion extension, good. So we have flexion, we have extension.
Abduction and adduction.
All right, abduction, adduction. And our last two is what?
Internal, external rotation.
Good. So we have all kind of 6 of those. Now, being the fact that we have 6 motions, that does not mean we have 6 degrees of freedom, right? We only technically have 3 degrees of freedom because they are paired motions. Somebody asked about this yesterday with degrees of freedom, because it looks like, actually, somebody emailed me about this. It looks like this should be 6 degrees of freedom. And we're not doing 6 degrees separation here with Kevin Bacon. We're just doing 3 groupings of motion because flexion and extension are opposite motions, right? Abduction, adduction, opposite motions. Internal, external rotation, opposite motions. That means we have 3 degrees of freedom at the hip, right? So that means it is a what type of a joint?
Triaxial.
Triaxial, right? So if the hip and the shoulder are so alike in their design, why does the shoulder then become a multi-axial joint? What does the shoulder have differently than the hip?
Like supination and pronation?
I'm sorry, what's that?
Is it supination and pronation?
Well, that's more at the forearm.
What about circumduction?
Okay, we have circumduction, good, which is the combination of a bunch of motions. And then we have one other set of motions that doesn't occur at the hip.
Circulation, is it? Oh, no, that's going to be circumduction too.
So remember, for the shoulder, I have add, flexion, extension, right? External, internal. But what do my pecs do?
Horizontal abduction.
We have horizontal adduction, and then we have horizontal adduction, right? We have that circumduction, which we talked about, which is the combination. And then we're going to talk about the shoulder also has one other motion that's kind of unique to it. That's called scaption. And we'll talk about that when we get to the shoulder, but scaption is kind of movement out here at a 45-degree angle. The hip really doesn't, you could do that, but we don't typically do scaption of the hip. So that's the difference between the hip and the shoulder is the shoulder does have a couple other motions. Could we do circumduction of the hip? I guess, sure. And PNF movements come into play with all of those, right? So we could do circumduction of the hip, but it's not considered a primary movement of the hip. The hip is primarily used for walking, whereas the shoulder is used for pretty much everything we do in everyday life, right? Think about all the stuff you've done since you got up this morning that you've used random shoulder motions for, right? I was thinking about it, so I was talking to actually a PT that I know because we were talking about some motions and stuff like that. And they said they had a patient the other day that just had rotator cuff surgery, And his whole complaint about after having the rotator cuff surgery was he couldn't scratch the middle of his back because he lacked internal rotation. That was his biggest complaint, is like, everything else is great, but now I can't scratch the middle of my back and I just keep getting itches in the middle of my back. I never thought about it, but I'm like, yeah, I guess, yeah, we take that for granted, right? We take for granted being able to reach back here and get to the middle of our back, but we all have that one spot though, right? That one spot in our back that we can't reach. That's where the itch always occurs. It's in that one spot that you can't get to. So we have all kind of this group of 6 motions in the actual hip, right? So let's talk about goniometry first. So with goniometry, let's talk about the positioning for it. So let's start with flexion of the hip. What position are we going to put the patient in?
Supination?
Supine.
Supine, yeah, supine, good.
Supination, wow, supine.
That's okay. That explains why supine and supination tie together, right? Okay. Then extension is the opposite. Extension goes in prone. And again, this is the way my brain works, and I'm hoping this kind of makes some sense to you guys. My brain works in designing these kind of horizontal trees when I'm studying, and I hope it helps you guys a little bit. How about for abduction? What position?
Supine.
Supine, good. Right? This is not to be confused with earth sign, which is bear. Okay, that wasn't as funny as I thought it was going to be. And then for internal and external rotation, what was the position shown in the video?
Short sitting.
Sitting?
Yeah, short sitting specifically. Good. So that brings me to the question, because somebody actually sent me a message yesterday about that short. That was a typo. Ignore that. Hopefully none of you caught that. We're gonna. That was a Freudian slip. That was such a Freudian slip, somebody logged off. Short sitting. All right. It's recorded. Thanks. See, that even shows that there's actually a lot behind that study of the way the brain works, but we're not getting into that. So short sitting is where you're sitting and your legs are bent at 90 degrees, usually off the edge of a table or even in your regular chair. That's technically considered short seated. So if we have a short seated, that means we have a long seated, right? And what's the difference between short seated and long seated then? Long seated, what happens?
Are your legs extended?
Yeah, your legs are straight, right? Your legs are straight out in front of you. So usually long seated, you're either on the floor, right? So when I think of long seated, I think of when you're like reaching down to do a hamstring stretch. That's kind of a long seated position, or where you're doing reaching over the toes. That's long seated. I'm sure that if that one person that emailed me didn't understand that, there's at least 2 other people in here that didn't get that. So I wanted to make sure I hit that short seated is kind of what you're doing at a chair, right? So when I'm sitting here, make sure I don't knock anything, right? When I'm sitting here like this with my knees at about 90, I'm short seated, right? Long seated is if my legs were straight out in front of me, which you really, I guess you could do sitting in a chair, but it's not really comfortable. Maybe if I had an ottoman in front of me, legs straight out. So those are our positions. So when I'm looking at this, I look at motion. I look at position. And I had a whole list of these when I was going through school, that I just had these little charts like this that helped me get through it. So then I need my landmarks. That looks like lamp marks, but it is landmarks. I can't write today. So the good news is with flexion and extension, the landmarks are the same, right? So first of all, I have to have my fulcrum. What's my fulcrum for this?
Greater trochanter?
Greater troch, good, right? Greater troch. And I know that the book, so here's the deal. When I'm doing this, I think back to mathematics. I don't think so much to goniometry. The book calls it the stationary arm. I think of it as a fixed arm because it's fixed to the goniometer. Whatever helps you remember it, but it's the arm that's not going to move, right? You remember what that fixed arm goes along?
Mid-thorax.
Yeah, mid-thorax, right? Midline of the thorax. Not to be confused with the midline of the thorax. That's a totally different thing. That joke will never get old. I love that one. And then my moving arm, what's my distal end I'm going to line that up with?
Lateral epicondyle.
Lateral epi, good.
Mr. McKeever,
Yep.
I don't know why my brain is spacing out, but what does it mean by the fixed midline of the thorax?
Sure, yep. And this time I actually, oh God, look, I just had it here. I literally just had my goniometer. I put it here so I wouldn't lose it. Oh, there it is. It went under my computer for some reason. I think the pixies are messing with me. All right. So when we have a goniometer, right? This is really the true part of the goniometer, the measuring part, right? The measuring part has a fixed arm. That fixed arm or the stationary arm stays with the goniometer. That's what we're going to be measuring off of. That's kind of our baseline line, if that makes sense. So I'm going to demonstrate, so don't worry. I just want to kind of go over the parts of the goniometer. I think that maybe gotten confused.
Yeah.
My movement arm is this one that actually does what? Well, it moves, right? So that's what we're going to use to measure my goniometry measurements off of. I got to get up higher because my camera's up here. So when we are talking about lining up the fixed line with the midline of thorax, I'm going to take this line here that's on the fixed arm, and I'm going to line it up kind of with the midline of the thorax to give me a 0 measurement so that I always start at kind of 0 here.
Okay.
So when I move you through the motion, I go, oh, well, I've got you past 90, so I've got about 110 degrees because there's my angle, right?
Okay.
Because it creates my angle. What I'll see sometimes is some people will go, oh, well, they've got 70 degrees. Well, they're reading off, there's multiple numbers on here. When we get to practice, I'm actually going to have you guys probably sign out a goniometer until we get yours in stock, just to practice a little bit. So I'm working with Dr. O'Neill on that right now. Because we actually ordered your gonies and we ordered your gate belts, so they're on the way, but I didn't tell you that. So the fixed arm is kind of our baseline arm. That's the line we go off of. So like if I was doing, just because I can do my arm easily here, right? If I'm doing elbow flexion, my fixed arm is going to line up with my humerus to create my 0 line.
Okay.
So that when I flex, I can move the movement arm and keep that other, it's kind of hard to do one-handed. There we go. And keep that other arm in line with it so it lines up on the humerus. Does that help a little bit?
Yes.
Okay.
I think I was just confused with, like you said, the
That's okay.
fulcrum. Thank you.
Yeah, no problem. That's why I wanted to cover this, because I actually got a couple emails last night, so I wanted to make sure I recovered this just to get it. So with the, and for those who don't know, those are ditto marks, meaning they're the same thing. Okay. I'm not going to rewrite it because I'm already having problems writing everything. I have too much caffeine today. So those are going to be the same. It's just now I'm prone. Everything else is going to be the same for prone. It's just I'm laying on my belly versus laying on my back. And I'm going to extension instead of going to flexion. So now I'm supine and we're measuring abduction, my leg going away from my body. Right? What is my fulcrum for ab and adduction?
The ASIS.
Right. The ASIS on the side I'm testing. Right? Because we have 2 of them, right? So if I'm testing my right hip, I'm going to put it on my right ASIS. I'm going to tilt this down some. Cable's tight. That's the problem. I got to fix that. All right. My fixed or my 0 line is going to line up with what?
The other AS.
Yeah, so an imaginary line going across the ASIS, right? So it's going to go one ASIS to ASIS. ASIS to ASIS. So if I'm standing up here, right? There's my ASISs. If I'm testing my right hip, fulcrum goes on the right hip. The line goes across those ASISs.
So that's kind of like a belt.
Yeah, it'd be kind of like a belt. You're exactly right. It'd be basically going across the belt line is really what it'd be going across, right? Or I guess that's the lower belt line because really the belt should be worn up towards the belly button, but whatever. We're not going to argue where the true waist versus the apparent waist is. Not getting into that yet. My movement is going to line up with what?
Midline of the patella.
Midline of the patella. Thank you, Diana. I was trying to get you guys not to use your book, but I appreciate you giving it. Yes, that would help. Page 286 is about where it starts. I was trying to.
I was just trying to like vision it. That's why. Sorry.
That's okay. I'm trying to work your brain. We're actually I'm gonna position myself through all of them. I'm just trying to work your brains here a little bit. Yeah. So midline of patella, right? Or mid femur, right? So when I'm looking at that, right? I'm kind of thinking, I would imagine the imaginary line going down through that patella groove as my midline or my movement arm. Good news is for both of these, they're the same. That makes it easy. Right? And so again, this is why I don't think goniometry is as difficult as you think it is. The hardest part about goniometry that I learned when I was going through school was figuring out what damn number I needed to read off this goniometer. For whatever reason, I screwed that up constantly. And it took me to think about, I have to think of what I see the range of motion as being, and then go off the goni. So if I see that they've got 90 degrees and I read that it's 140, I'm reading the wrong number.
Mr. McKeever, for mid patella, obviously the movement arm can't get down that far. So are we just basically eyeballing it and making
sure a line going down? Yeah. And I ordered a couple of there's a couple of new gonies to practice with so that you can get a better kind of practice with it. There's a goni that actually has an extendable bar that I ordered that will help us at least in the first time practicing. So you go, okay, I can extend that bar down that way. They're a little bit expensive and well, too bad I put them on expense report. Dr. O'Neill can yell at me later. Anyway, that's on recording, isn't it? I was kidding. But I ordered a couple of those just for practice. They're really expensive, and once you get the idea, you don't need that as much. But I think for practice, it would actually be useful. So I ordered a couple of those. Hopefully, they come in. Last time I ordered, and they canceled my order. I was very sad. But they've got them in stock now. So, all right. So internal external rotation. I'm now going to be short-seated, right? So now that I'm short-seated, I'm going to have to figure out what my fulcrum is again, or my rotational point. So for those of you that have the book, or if you want to guess, what is the fulcrum for internal and external rotation?
It's the knee, right?
Yeah, right. I believe the book says mid patella, if I remember correctly again, or midpoint of the patella. Now, I'm going to warn you here. Some clinics will use the tib tube. Here's my comment on that, and here's why I say don't do that. Because is the tibial tuberosity at all attached to the hip?
No.
Right. So I know some clinics do use that, and if your clinic uses that, that's going to be one of those where you just go, well, I know what the book says, I'm going to do what the clinic tells me to do here, and I'm not going to argue it, right? But the book is about the kind of the midpoint of the patella, is what they say it is. The fixed arm is going to line up with what?
Perpendicular to the floor.
Right. So does anyone know what the perpendicular sign looks like in math?
Yeah, it's a straight line down on a horizontal line.
Yeah, it's basically an upside down T, right? Perpendicular to the floor. And again, this is another one you kind of have to eyeball, right? I mean, am I 100% perpendicular? Am I off by 5 degrees? Yeah, right. We try to go as perpendicular as you can. And then the movement arm is going to line up with what from that yesterday?
Still the mid patella?
The tibial crest.
The tibial crest, right? And what is the tibial crest? Because I actually had somebody ask me that again. Last night I got a couple of email questions, so that's why I wanted to recover this. Somebody said, well, Mr. McKeever, I understood everything, but I don't remember what the tibial crest is.
It's like your shin bone, right?
So in the martial art, I can't get my leg up here. In the martial arts, tibial crest is that line that goes right down your tibia, right? It's a sharp point of your tibia. In the martial arts, that's what we use to strike with. It's also the part where if you're walking around your house and you run into a table that you're probably going to hit the table with, right? And it's going to leave you a nasty night. I've got a bruise on my neck, actually. Yeah, it's right there. It still hurts. I walked into one of the tables in the hotel because my room was built. Yeah, it's a dishwasher, the dishwasher door. Exactly. It's perfect. The sharpness is just perfect for making sure you hit it. Actually, no, I remember what this was from. I rented one of the new Camrys, and they have this little door on the driver's side that kind of pops down that you're supposed to be able to store stuff in, but it was broken. So it constantly dropped down. So I'd get in and bang my shin off of it every time, and it hit my tibial crest every time. All right. So does that make sense overall for that?
Yeah.
I wanted to pull something else up real quick. Labs. So does that help at least clarify the landmarks? Like that at least makes it more sensible to you guys, I assume. And again, dittos for that. Let me switch sharing. So I did create this for you guys, and it is up in your labs folder. I hope this becomes helpful. I would take this and I would put this into your binder. I think the page numbers are right. I think I have to go back and check that because I think we've upgraded books since I actually wrote this. I know it says competency at the top, but mainly for me, it's all of your measurements that you possibly could need. So literally we can go down here and go, and when we actually have when we practice this, I would really like you guys to have this sheet with you at all times when we're in lab practicing goniometry. Because when I say, what's your normal? So let's say I'm your CI, and I say, what's normal for hip extension? And you're like, I don't remember. Let me look is the right answer. Right? I don't quite remember right now. Let me look real quick. And you have that handy that you can just go instantly. I was such a geek that I took this sheet and I printed it out and I made it really tiny and printed it out and almost the size of like a 3x5 card. And I printed it front and back, and I kept that 3x5 card in my back pocket so that I always had my goniometry measurements with me. So that if I forgot, I could always compare off of it. The one thing I want to comment about this is this hip flexion. Remember, this hip flexion is with the knee bent. The true measurement here is with the knee bent. With the knee straight, we're testing a combination of hip flexion along with what length?
Hamstring.
Hamstring length. Good. And again, most clinics we're going to test both. But the true measurement of hip flexion is the hip flexed. Or the knee, I'm sorry, well, obviously the hip flexed. Derp. That was on recording too. That's great. With the knee bent.
So I have a question with these angles too. So that's the normal, but if we're testing, like say somebody is testing like the left, if they have like, an injury on the left side and their right side, their uninjured side is less than 120, we're still comparing it to their uninjured side, right? We're not necessarily comparing.
Yeah, well, we're going to do a kind of a double comparison, right? We're going to compare it to norms and also against their unaffected side. Trying something different today. I got Dr. Pepper Zero. They spent 15 years making it. No, just kidding. Just like the commercial. Yes. So we're going to compare it to both. We're going to compare it against normative values, right? What the book says. But let's face it. If we've got 75-year-old Millie, she ain't getting 120 degrees hip flexion, right? There's just no way. But let's say she gets 60 degrees on the left, but she has 90 on the right. We know that 90 she can reach to. So we're going to use that as kind of a combination. Yeah, there was a hot Dr. Pepper. You're right. And Coke used to have cocaine too, but that's beside the point. Those were the days. I'm just joking. Whoever's listening, if any of the people on PIMA watch this video, I'm just joking.
Mr. McKeever, I have a question. So on the left side, we have the measurements, and then on the right side, what is it?
What is your Daniels book?
I don't know.
The one you just referenced.
Oh, okay.
That's your manual muscle testing book.
Oh, okay, okay.
Right? So I have to, maybe I should have labeled it better. I apologize. I tried to, let me see. Yeah, so manual muscle test up here, goniometry over here. So I tried to make it so that you had both of them in case you needed to look up what the manual muscle test was, you could look it right up. If those pages are not right, please let me know. I will update them. I thought I had it updated last semester, but I may not have. My brain sometimes melts down. So let's, I think it was Amanda that was asking, I was not paying really attention. Let's say we have a patient who their left side is their affected side and they've got 25 degrees of hip abduction, but on their right side, they've only got 30 degrees. So when we're looking at that, at least from the PT's perspective, not from our perspective, but from the PT's perspective, they theoretically could set goals for both hips, right? Because we could even set a goal for that right hip to get to what is considered normal if we wanted, right? But our main goal should be to do what to these measurements? Make them what?
Get them to be the same.
Yeah, get them to be equal, right? Because right now, that 25 degrees is less than the 30 degrees. So we want to get them as congruent as possible. That's a great way of looking at it, Brooke, right? We want to try to get them to where they are as equal as possible, you know? Now, with statistical variation, it's going to mess up their walking, right? So with statistical variation, there's this thing called minimal, drop the E, clinically relevant, or the MCR. Does anyone have an idea what that might mean? All right, I'll fix them. Thank you, Amanda. Dang it. I'm just having a bad day with speech today. I think I have my TBIs kicked up. I'll just call that. I will fix that then. I'll go through and reevaluate them all, and I'll repost it.
Does it mean that it's not necessarily relevant to their goals?
Yes, good. That's kind of right along the right thought process. So when we're talking about goniometry, there is an MCR of 5 degrees. And what that means is, unless they make a change of greater than 5 degrees, it's not a relevant change. Why do you think that might be?
It's not enough to fix the problem / reach their goals.
Okay, there's one of them. It's not enough to fix the problem and reach their goals. What else do you think it could be?
Kind of like an over/under on mistakes.
There you go. Good, right? All of us have a certain variance in the way we do things. So what that 5 degrees is kind of that variance. We should, like, if John does goniometry, thank you, Amanda. If John does goniometry and I do goniometry, we should be within 5 degrees of each other. Even if we do things a little bit differently, we should be within 5 degrees. So unless the patient goes over that 5 degrees, we can't say they've actually made a change. And we have to kind of temper our patience with that, because especially in somebody that's lost a lot of range of motion, if we suddenly tell them, oh, you were at 20 yesterday, you're at 23 today, they start freaking out. They're like, yes, I made a big change. Hold on, wait a minute, something ain't right. We have to tell them, yeah, 3 degrees is big, and I'm not going to downplay that, but we really want to get more than 5 to say that there's definitely a change. Yeah, so only if it's past 5 degrees. So we really can't say the patient has made a drastic change until we see like 6 or 8 or 10. So like Brooke, you and I could do a measurement, and I may say that it's 61 degrees, you may say it's 64, but we're within that 5 degree variance. Does that make sense? Cool. Now, when we look at stuff like hip adduction, where there's only 30 degrees, that 5 degrees is pretty significant, right? Because I mean, there's only 30 degrees to begin with. That's 1/6 of the total range. But up here in the hip, you can understand how that 5 degrees is kind of important because they've got 120 degrees that they're supposed to have. 5 degrees isn't much of it, right? Or when we get down here, like subtalar inversion, eversion, which you guys won't have to do, but we'll talk about it. They're only 5 degrees to begin with. So theoretically, even when we measure it, we could be within our standard of error. That's why small motions like this are really not as, I want to say ethical is not the word I want to use. Not as clinically relevant is probably a good term, because it's really hard to, even when we have, where are my other gonies? Where's my bag of gonies? Is my bag of gonies down here? Oh, sorry. Yep, there's my bag of gonies. This is my little bag I carry with me everywhere. Where are all my other gonies at? So even when we're using, come on, I haven't broke this goni out in a while. Even when we're using a small goni like this, right? It's really difficult to say that 5 degrees is actually relevant. So it gets difficult. And when we get down to those small variances, we have to kind of pay attention to what we're doing and be really specific about it. And that's why a lot of times you won't see PT set goals for these type motions. They may set goals for getting to subtalar neutral, but they don't set goals for inversion, eversion of subtalar. Yes, got a question?
Yeah, sorry. You kind of brought that like smaller goni out. I kind of probably just missed this, but like, for example, like when we're working with like fingers or hands, and it doesn't move too far, do we still disregard that? Not disregard, but like it's not as relevant, like you were saying?
Now, granted, so this actually is a finger goni is what this is, right? So I'm going to lay my finger on it. Let me get, what side is there? Right, so I'm going to lay my finger on it, and when I do motion, it's going to move, right? And so I'm going to line it up so I get my finger range of motion. We're still going to document it, but we have to understand as clinicians, at least, that it's a lot harder. Well, in the fingers, we have more motion, obviously, right? But we have to understand that when you have those really small, like I said, specifically subtalar is the major one. And I actually I was looking at this last night because I was trying to see how relevant subtalar inversion, eversion, goniometric measurements are. And almost nowadays, it's kind of considered passé or not really to measure that as much because there's such a chance to error, right? I could measure and get 3 degrees and be like, oh, they got 3. And then you could measure and go, I've got 1 degree. How are you getting that 3 degrees? Again, that's within error range. And how can we say that? That's not something we could definitively document a change on, if that makes sense. But on ankle eversion is 15 degrees. We definitely could document a change on that because we've got a greater than 5 degree range, if that makes sense. But yeah, the gonies, the gonies are designed to become more accurate as they get smaller, but that doesn't mean that we're not going to have some error there. There's going to be human error, right? We're human. We always make mistakes, or at least some of us do. I know Diana never makes a mistake, so we can't ever say that. But we all make a little bit of mistakes every now and then. But does the MCR make sense to everybody? Because that's kind of an important thing to get. So I will fix, Amanda said the MMTs are not right. I will fix the MMTs. I think this was off of the 6th edition book, so I will go and fix those and re-upload that. This should be within the range of those pages, but may not be the exact page. So let me grab my little notepad here. Fix Daniel's pages. See, I am receptive to change. All right, let me go back to my whiteboard real quick. All right, so we've got those. That's kind of the way to go through when when I'm designing stuff for my own brain to study, I need to do stuff like this because just looking at the book doesn't help me. Just watching a video doesn't help me. I need to physically write something down so that it sticks in my brain. I hope that helps you kind of my thought process on going through this. I'm going to do this with all the joints because it helps me when I was doing it. All right, any questions on the goniometric side of things? Are we good for the gonies at least? And again, not until we practice, right? Obviously, but at least the groundwork is there, right? We've laid the groundwork. We're going to build upon the ground. We've laid the foundation. We're now going to build the building. All right, let me close down this, stop sharing. And we're going to go over to we're going to watch the videos on manual muscle testing, then I'm going to walk through them. So let me go over here. So I'm going to share this. I want to move this over to the other screen so that I keep everything consistent.
A little bit off topic, Mr. McKeever. Our
What's that
midterm
saying?
next week, are we gonna talk about that a little bit?
What's that?
Our midterm is next week.
That's part of today, yes.
Okay.
Yep, that's part of today. That's why I have that's why I have 4 hours today. So I was like, okay, I don't want to hit you too hard with something fresh when the midterm's coming up. All right. So, yep, there we are, share. All right, so now we're going to look at some goniometry. We're going to look at flexion, extension, abduction, adduction, internal, external rotation. So these videos are up in your lab folder again. I have it all divided by upper extremity and lower extremity for you. These are straight from your Daniels and Worthingham book, which is your manual muscle testing book. So these are done as technically proficient as possible for a video, meaning these are really good examples for it. There are plenty of other videos, I'm going to say, on YouTube that I found that are a little bit more higher quality because these are really small videos. But, oh crap, I just realized I didn't click share sound. Hold on. My brain did not click that. I wish I could just default that. It doesn't let me default it. There we go. All right. So let's hit play. So we're going to watch flexion first. But before we get started, what position do you think we're going to test hip flexion manual muscle testing in?
Sitting.
Good. Short sitting, right?
Mm-hmm.
The gravity-resisted test for hip flexion begins with the patient's
Holy farmer's hand, folks.
seated, thighs supported, and legs hanging over the edge. The patient flexes their hip to end range, maintaining neutral rotation, and holds that position against the examiner's downward resistance.
Lift your leg off the table. Don't let me push it down. Relax.
Okay, so I'm going to call out one thing on this technique here. It's pretty bad. I'm going to test that. I'm going to call out one thing on his technique here. What is he not doing to the patient?
Making him
Stabilizing?
Stabilizing. Good. Yeah. Making him feel safe. Right? Go ahead.
Is the patient like cheating too with their arms?
Yep. And why is the patient cheating with the arms? Because the clinician's not stabilizing him.
He would stabilize him with the lower back, right?
Yeah, so somewhere on the back. So what I would tend to do with this patient is I would put one hand behind kind of their back and up to the shoulder, like kind of shoulder blade region to give them stability, and use the other for the break test.
Okay.
Right? Because then I don't like my patients to grab onto things because then they can kind of use their arm muscles to support it for sure. And he is leaning back. You're exactly correct, Riley. He's cheating a little bit that way too. And why do you think he probably is doing this? He's probably tight. Right? I don't think he's actually intentionally doing this. This kid's probably tight. I've got a better goatee than his. Just saying.
Grade 2 hip flexion is evaluated in sideline, with the limb to be tested up.
Does that dude have a mullet? I think he's got a mullet.
Most. The trunk is neutrally aligned and the lower limb may be flexed for stability. The patient flexes the supported hip. The knee is permitted to flex to reduce hamstring tension. The therapist supports the test limb and prevents the pelvis and trunk from rolling.
Bring your knee up toward your chest.
Okay. I'm going to comment on her body positioning here. And this is actually a good lesson because I haven't watched these in a while, so now I remember having this last semester. Let's talk about body positioning here. What do you see bad about her body positioning?
She's twisting a lot.
Good, right? Look at her low back too. She's really bent over, isn't she? She probably could have adjusted this table better for her. But there's another thing I'm noticing that I'm not really comfortable. Yep, thank you, Joe. Right now, again, I've said that, and Dr. Breskin will be 100% adamant about this, that your chest is not a working surface, ladies. I don't know why it's just ladies, but no, I'm just joking. I know why. That being said, in the rehab and like inpatient facility, use what you got. If you've got to use your chest as something to help support stuff, use what you got, right? But I'm just saying, in this position, she could have probably stood in the front and not kind of put herself in that position. Now, what if she wanted to stand in that position? What could she use as a barrier between her and the patient?
Like a pillow?
Yeah, a pillow, a towel. I would just because, and I know guys, right? I'm just, because I am one, last time I checked. Could this patient take this the wrong way? Yeah, right, Brooke? And that's the last thing you want to be put, like you're in a room doing manual muscle testing with a patient by yourself, and this patient takes something you do the wrong way, right? That's not something you want to happen. So there are a couple of things that I have a problem with here, but yeah. And she is doing no resistance. She's just taking the weight of the leg off the patient.
Would it be easier for her she's on the other side?
That would be preferable to me. I know what she's doing there. She's trying to get out of the way of the video, and she's trying to let the patient have some range of motion, but she could just as easily step back as the patient moves the range of motion to be out of his way. Right? Yeah. There are a couple different ways I could do that. Yep, go ahead.
Sorry. So for a grade 2, would you test them in sideline or?
Yes, position is right. Position is right because in that position you've eliminated gravity. In reality, you've reduced it, right? But yes, so the position for him is right. Her position is just kind of wonky.
Okay.
Grades 1 and 0 are assessed supine with a test.
I've never heard it called supine before, but whatever.
Supported by the examiner under the calf. The patient attempts to flex the hip. The examiner's free hand palpates the muscle just distal to the inguinal ligament on the medial side of the sartorius. Palpation of the iliopsoas can be challenging. First, identify the location of the sartorius by placing the heel of the subject's test limb on the contralateral shin and palpating for the sartorius. Once the sartorius is located, move the palpating hand medially to locate the iliopsoas.
So remember, for this, she's just looking for a trace.
Try to bring the knee up to your nose.
So I'm going to give you my hint on that one. Again, for a trace, you're just looking for that muscle to kind of quiver, right? So get something out of it. My trick to finding iliacus or iliopsoas, right, is I find that place where I find the inguinal pulse, right? So the pulse right in that inguinal canal or that femoral triangle. And I just kind of push right in that region. I can get a palpation on the iliacus or iliopsoas, whichever you want to call it, by putting my fingers in that position. I also then lay my palm across the quads, because if the quads fire, I still am getting a trace on iliacus. So I'm okay with that. And again, if we're down here at this grade 0 and grade 1, anything we get is better than nothing at all. Does that make sense? Because when we're down at 0 and 1, that's a severe neurological problem with this patient. So again, testing position for 3, 4, 5, short seated. Testing position for 2 and under, kind of side lying is best because we want to eliminate gravity. And for 1 and 0, I usually test in side lying too. I don't really move the patient at that point. You could if you want. You could test the patient seated if you wanted to for that. It really doesn't matter where you do it. And yeah, Brooke says knee to chest now. Exactly. All right, so that is flexion. Let's do extension next. Let's see how bad the body mechanics are here.
The gravity-resisted test for hip extension begins with the patient prone, unless the patient has a hip flexion contracture. The patient extends their hip through the entire available range of motion. The clinic.
Okay, already I found one. What do you think my problem with this person's testing technique is?
The where his hand is on his back, it should be on his hamstring.
Okay, that could be. Okay, that's not bad. He's trying to support and trying to keep from cheating, so he at least has gotten better there. What about that testing hand? Let's look how far down the leg that is. What has he done to that force arm?
It's like created more torque.
Yeah, he's created a ton of torque there, right? I guarantee if you test somebody, and we'll try it when we do the medium muscle testing clinic. If you put that, if you're torquing and doing, not twerking, torquing, I said, torquing that down at the ankle. I'm sorry, I'll try to figure, maybe I need to just go to headphones for me. That might be an option. Let me think about that. Thank you for giving me that feedback, Riley. I apologize, but I may just go to headphones for when you guys are responding to me. When you're pushing down at that ankle, you're putting such a long force arm there that I guarantee even John is going to cramp here. Where would be a better place to put his force arm? Yeah, well, gastroc, okay. Popliteal fossa is probably a good idea, right? Or just above it. And I actually, when I'm testing this one, my hand position goes right here, just above the popliteal fossa. Because again, we're not testing healthy people, right? We're testing ill people, and they're not going to have a lot of force there. And then if I put my hand there, like Diane said earlier, I can actually feel his hamstring too, right? I can actually feel if I've got a contraction. So I don't like his positioning here. I know he's probably testing because this person's healthy and got some strength. Not a good idea, though.
Stabilizes the pelvis with one hand and provides downward resistance just above the ankle with the other hand.
So let's say again, we're going to do this and you're going to give the patient a cue. So you got the patient position and you tell them, lift your leg off the mat and don't what? How would you describe what you are going to do?
Don't let me leg down.
Yeah, don't let me push your leg down. Good. Remember I said simple commands, right? Don't be like, and resist me and do not let me push your leg into hip flexion. No, simple commands. Pick your leg up. Don't let me push it down, right? Move your leg out. Don't let me push it in. Move your leg up. Don't let me push it down. Move your leg down. Don't let me push it up. You want to be pretty specific. And he is using his upper extremity probably to generate some more force. You're probably right, Joe. I'd be willing to bet he's up there. I mean, look, he's grabbing a hold under that table. He's cheating a little bit.
Alternatively, resistance can be
Oh, look, it's almost like I planned it.
applied to the posterior thigh just above the knee. This is a less demanding test.
And the probably better way to do it.
Lift your leg off the table as high as you can without bending your knee. 4,
3, 2, 1.
and relax.
John, maybe we should do some videos. I think you're right. I think we need to do some of our own
Grade
videos.
2 hip extension is performed sideline with the test limb uppermost. The examiner provides support for the limb and the knee is maintained straight. The opposite hand is placed over the pelvis to maintain alignment of the pelvis and hip. The patient extends their hip through full range.
Bring your leg back toward B. Keep your knees straight.
Simple commands.
The test to differentiate between grades 1 and
Yeah, so remember with grades 5, you ideally want to count them to hold for 5 seconds. And I always count because, Amanda, if I'm pushing down on your leg, you kind of want to know when I'm going to stop, right? Because if I say, don't let me push your leg down, and I'm sitting there and I'm just twerking on that leg, you're like, well, how long do I have to hold this? Right? So I say, okay, don't let me push you down. I'm going to push for, I may say, I'm going to push you for about 5 seconds.
Okay.
Or I may just count. Does that make sense?
Yeah, because they were doing like 3 seconds in the video. That's how it.
Yeah, 5 seconds is the standard.
Mr. McKeever,
Uh-huh.
I'm just confused with the grades and how they keep changing on here. It has to do with the gravity, but I can't grasp it.
That's okay. We're going to re-go over that in a second. So if you hold that question until we go through the videos, we're going to go over that again in a second. Can you hold that for about 5 minutes?
Yeah.
Cool. We're going to that's going to be my whiteboard draw out in a second.
Okay.
0 is performed prone. As the
Okay. Here's one of those that you can't get away with. You've got, in order to test for this, you have to test the distal end of the glute, and you're going to be touching the patient's butt. And there's no way around it, unfortunately. So just make sure that before you do this, you let them know, and you also do not reach up their shorts to feel their glute.
patient attempts to extend the hip or squeeze the buttocks together, the therapist palpates for the hamstrings at the ischial tuberosity.
She says things weird.
The gluteus maximus is palpated over the center of the buttocks. Contraction of this muscle will result in narrowing of the gluteal crease.
Possibly, yeah.
Try to lift your leg from the table.
So again, we're going to go over the grades, review the grades one last time. Yeah, whole professions just don't make it weird. You're 100% right. Because we're going to do some talking about pelvic floor stuff in 5th semester, and that really, you have to make sure it's not weird. Because for some of you, and I don't know if you guys are aware of this, you can test for contraction of the pelvic floor, but the pelvic floor is in your pelvis. So there's only one way to test for the contraction. I'll leave that up to your imagination for right now. All right, so now we're doing abduction, abduction.
The gravity-resisted test for hip abduction is conducted with the patient sideline with the test limb uppermost. The limb should be slightly extended beyond midline with the pelvis rotated slightly forward. The patient abducts their hip through the complete available range without flexing or rotating it in either direction. Resistance is given in a straight downward direction at either the knee or at the ankle if a longer lever arm is desired.
Lift your leg up in the air. Hold it. Don't let me push it down.
Now, she's an experienced clinician here. I can tell by the way she just did this. You don't necessarily have to bring the leg back into extension like she did. But she's probably done this a million times and didn't even think about herself doing that. Why do you think she brought the leg back into extension slightly? What might be the advantage?
cheat.
Yes. Right? If she brings it slightly back into extension, he can't cheat with his hip flexors. So yeah, she probably didn't even think about doing that. When I do this, I really don't do that, to be 100% honest. I just test it from straight and it's fine. It's okay. You won't get in trouble for testing it from straight. You don't have to bring it into extension. But I've known a lot of old school clinicians that do this, and I bet she just didn't even think about doing that. Let me rewind it a second here. You'll see what she did.
In the air,
She's got it back.
hold it. Don't let me push it down. And relax.
I didn't like the way she applied force there because she almost applied it in a ballistic manner. I don't know if you saw that. She was kind of bouncing up and down. You want a nice steady force. And it may be that he actually was just stronger than her. That's a possibility. Again, we're going to go over the grades. Don't worry, Brooke. I got you. And Brooke just figured out what I was talking about.
The gravity minimized test for hip abduction is performed supine. The therapist supports the test limb just enough to decrease friction.
Supine.
This hand offers no resistance, nor should it be used to offer assistance to the movement. The patient abducts the hip through the available range, while the therapist palpates the gluteus medius, just proximal to the greater trochanter.
Bring your leg out to the side. Keep your kneecap pointing to the ceiling. And relax.
Oh man, he's got some serious pelvic obliquity going on there. I'm just sorry, I just happened to catch it. I don't know if you guys can look at this.
Is that not just the angle of the camera? Is that
It
actually-
could be. It could be. You're right. And now that I think about it, it could be the angle of the camera. But I would be willing. I would be interesting to do a what do you call it? A leg length test on him. I wonder if he actually has pelvic obliquity, or if it's just he's laying in a weird angle. It's just the position of that camera angle I'm looking at right now goes, man, that looks off. I have bunny ears. No, just kidding. All right, so now we got AD deduction. Same positioning. Yep, absolutely, Diana. Good question. Do we do? Diana asked, "Do we do manual muscle testing for peds?" We sure do. And now remember, if I'm testing a 7-year-old for manual muscle testing, I'm not going to be putting huge amounts of force on them because that wouldn't be very fair. Usually, when I do pediatrics, I limit my force arm to 2 fingers, unless I've got a really big kid. Then I may.
Is there a specific age where we don't do them?
I'm gonna say toddler. So like, we'll talk at 5 and under maybe. There's not really a specific age. It's just that when we get down into those ages, we actually have different tests for it, which is called the Peabody Developmental Motor Scale, the PDMS, where we have them perform activities rather than manual muscle testing. So we might have them do a jump or something like that, that will substitute for a manual muscle test. So yeah, I would say toddler probably. Yeah. Let me take it back just a second.
The gravity-resisted test for hip adduction begins in sideline with the test limb
Look how happy they
lowermost.
are.
The upper limb is abducted approximately 25 degrees and supported by the therapist. The patient adducts their lower hip until the limb contacts the upper one. Downward resistance is applied on the medial surface of the thigh, just proximal to the knee.
So the first thing she's going to do is get that upper leg out of the way. Now, there are a couple ways you can do it. You can do it like she's doing, where she's going to hold it, or you could just put the leg in front of the other leg. And I'll show that when we're doing exercises again. See, that's my problem with that technique, is she can't stabilize when she's holding that leg up there. So what she could do, and most books will have you do, right? What most books will have you do is take that leg and move it up here. So it's kind of laying on the mat. And then you don't have to hold that leg anymore.
Like when you're doing, like four-way hip.
You got it. Yep, exactly.
Okay. Okay, thank you.
Good way to kind of integrate knowledge. You are in the associative phase of motor learning.
A minimized test for hip adduction is performed supine, with a non-test limb positioned in some abduction to prevent interference with the motion of the test limb. The therapist slightly elevates the test limb from the table to decrease friction as the limb moves. The patient adducts the hip without rotation while the therapist palpates the adductor mass on the inner aspect of the proximal thigh.
Well, you may be in the associative phase still, but that was, or a cognitive phase, but that was an associative comment. So I just wanted to use that as a learning tool. All right, so we get external and internal rotation. Okay, real quick before we do these. External rotation, which way is the knee pointed?
Out.
Out, good, okay. Right, even though the foot is technically in, right? You'll see that in the picture, the thing here.
To begin the gravity-resisted test for hip external rotation, the patient is seated. The patient's hip is externally rotated.
So with this one, because I know somebody's going to ask me about this, with this one, it is actually okay for them to hold on to the table because we're going to be kind of on the floor for this, and we're not going to be able to support them as much, and they can't cheat. There's no way of cheating with the rotators, really, other than leaning your trunk, and you can clearly see if they do that.
The patient holds this position while the therapist grasps the leg at the ankle and knee and attempts to internally rotate the hip.
I'll talk about that in a second, John.
Hold here. Don't let me turn your leg out. And relax.
Because there's another thing I don't like about this. I always find a lot of things I don't like.
The gravity minimized test is conducted supine. The test limb is
Something just looks really weird about that position she's in.
internally rotated. The patient attempts to externally rotate the hip, while the clinician ensures that the pelvis remains neutrally aligned on the support surface. The external rotator muscles, except for the gluteus maximus, are not palpable.
Try to roll your leg out. And relax.
So she was not palpating there. Yeah, she just looked like this way. All she was doing was stabilizing the contralateral hip. And now I know they just said that the external rotators are not palpable, blah, 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 blah. I don't agree with that. I agree that I think you can palpate it, but you have to get pretty deep in the buttocks to palpate them. So when I'm palpating, I typically will do kind of a almost like a finger cup where I'm coming in. So I'm going right there. So if you got that kind of midline where your butt crack is, I'm coming just lateral to the butt crack, and I'm going to dig into that piriformis. When if I've got somebody that's a 2 or a 1. So, and I'll demonstrate that one in the clinic too. I can kind of talk about it in a second. So John asked really quick, since this video is done, how far out on the table should you have them sit or whatever? I didn't ask you to play again. I typically have them about 3 inches of space between the table and the popliteal fossa. It's not an exact science, John, but that's about when I went through school, that was what the book said, and it's kind of stuck in my head that you need to have 3 inches of space between the posterior aspect of the popliteus or the popliteal fossa and the bed. And the reason they said 3 inches is that was the average width of a gastroc, was about 3 inches. Now, some of you have smaller gastrocs and some of you have monster gastrocs like I have. You may have to adjust accordingly. The other thing is, when you have a patient like this where you're doing internal external rotation, just like if you're doing manual muscle testing, they should have a little towel roll under that leg. It does 2 things. It allows them, it takes away, it puts the hip flexors a little bit on active insufficiency so they can't cheat with them. It also allows a little bit smoother of a glide on the table, so it doesn't bug them as much. Let's do external rotation or internal rotation now.
The gravity-resisted test for hip internal rotation begins with a patient seated. The patient's hip is fully internally rotated. The patient holds this position while the therapist grasps the leg at the ankle and knee and attempts to externally rotate the hip.
I'm just going to say, ouch. That body position. Oh my.
Don't let me turn your leg in. Hold it. The gravity minimized test is conducted supine. The test limb is externally rotated. The patient attempts to internally rotate the hip. Gluteus medius can be palpated proximal to the greater trochanter. Tensor fascia lati is palpated over the anterolateral hip, below the ASIS.
Roll your leg in toward the other. And relax.
Okay, so let's stop sharing there. Now that's the basics for manual muscle testing. And again, I'm gonna kind of do a, like I did with the manual muscle or with the goniometry, we're gonna do like a whiteboard kind of draw out to kind of help Brooke and everyone else with the level 2s, level 1s and stuff like that. Do we need a break before we do that? Or do you want to just go into it a little bit and then maybe take a break halfway through it? How are you guys feeling? I know we didn't do much yet. That's why I want to make sure. Are you guys okay to keep going a little bit longer? Okay. As long as Riley says keep going, so Riley's the vote. No, just kidding.
Got a question though, Mr. McKeever.
Yes.
So in terms of, the grades, when they say like full range of motion, and you probably went over this already,
I was ready to, because I think I know what your question is going to be.
Does it, does it have to be like the full, like the values that we have?
So here is, I'm going to give you both the official answer and the unofficial answer for that. Okay. Because officially, if you can't achieve 100 degrees, 120 degrees of hip flexion, you can never technically have a 5 out of 5 hip strength.
Correct.
Right? Officially, that if you read the books and follow the letter of the law, I guess not law, but letter of the rules. But in reality, we don't do that. We go off of functional range of motion more. So what they have, if they can move, if they've got, 95 degrees of hip flexion and I can push down and they resist fully, that's still a 5 out of 5. Right? Okay. Because it'd be really hard, especially if you're like testing somebody that's had a recent amputation or something like that, for them to get full range of motion. So yeah, I mean, by the letter of the rules, technically, if you don't have full range of motion, you can't get a 5 out of 5. But if we did that, that means absolutely none of us, like maybe Diana might get full hip flexion. I don't know. But I guarantee Jason and I are probably not getting full hip flexion. And he's like, nope, we're going to be 2s because we can't even get full range, or 2 minuses because we can't even get full range of motion. But I guarantee we can resist somebody pushing down on us. So we kind of have to temper that a little bit and go, well, they've got functional range of motion.
For sure. Thank you.
No problem. And that was I was going to talk about that with this. So that was perfect. I'm like, read my mind, man. That's all I'm saying. It's kind of creepy. All right. So whiteboard is back up. So we're going to start doing that same kind of drawing thought process here. So I'm going to put flexion. I could type this, but I find writing is much better for me. Should just go to my tablet and use my pen. I mean, my computer's got a touch screen, but that's over there and it doesn't work as well. Ascension, ABD, ADD, ER, IR. All right. So first thing we're going to talk about is with manual muscle testing, so we're going to do MMT here, is positioning. So I have positioning. What is the positioning? And again, we're going to talk positioning for 3 through 5. And then we're going to talk positioning for 2, 1, 0. So positioning for hip flexion for 3 through 5 is what?
Short sit.
Yeah, good. Short sit. Just sit. Now that means that I have gravity. And this is where I think Brooke got a little confused. Because if I'm sitting down, right? If I'm sitting here and I bring the leg up, I'm going against gravity. That's the idea for 3 through 5, right? So I am moving in what plane when I do that?
Sagittal.
Sagittal, good. Right? So in order to eliminate gravity or reduce gravity, I have to move to a frontal plane motion. And in order to do that, I have to move into what position for 2, 1, and 0? Sideline. Good. Right, so now when I lay on my side, I'm kind of going like this. And I'm not, and again, the book says eliminating gravity, but we know through Newtonian physics that we can never truly eliminate gravity. Unless you're a flat earther, then gravity doesn't exist. So I'm going to go down through all the positions, and then we'll talk about how to test them. So with hip extension for 3 through 5, what position are we going to put them in?
Prone.
Prone, good. Now, is there an alternate position I could put them in maybe if they can't sit on their, can't lay on their belly?
You could also do sideline for extension.
I'm sorry, was that sideline for what?
Sideline extension.
Okay, you could, but again, if I go sideline, right, because that's going to be over here, and sideline, I reduce gravity a little bit.
You can also.
I heard somebody say it. What was that?
Standing.
Standing. Now, in order to go standing, I have to have functional what?
Lower extremity.
Lower extremities, yes, and I have to have functional balance, right? So this is not a preferred position. But if I've got somebody that's got serious belly or pregnant mommy, right? I can't test pregnant mommy on her belly. So what I can have them do instead, and I'll bring up the other camera in a second, is I could have them lean on something and do kind of the same motion, right? But just be aware that I have to have pretty good balance in order to do that. Or I have to have a gait belt on them and really be supporting them, which it gets a lot more challenging. So I could do standing. Sideline works. I mean, again, if it's in a pinch, I could do it. Like, especially with a pregnant woman, I typically do sideline even for this, because I can put enough force to test if she's a 5, 4, or 3. But it's just, you've got to, when you have situations like that, this is an alternate position, but it's not exactly the best position. Just like for this one, for a flexion, technically I could do an alternate position of supine if I needed to. But if the person can't sit, they probably can't lay supine. I'm just saying. So sideline again is going to be my gravity reduced. So grav reduced. All right, so for hip abduction, what position are we going to be in to have gravity?
Sideline.
Sideline, specifically with leg up. And when I say leg up, or maybe leg top would be a better term for it. So if I'm testing my right hip, that right hip has to be on top, right? Otherwise, it doesn't work out very well. I'm pushing into the mat. And mat doesn't like to be pushed around. Ha, ha, ha. Okay, fine. It wasn't that funny. It's funny to me in my head. But I'm very funny in my head quite a bit. So for the position 210, I have to be in what position?
Supine.
Supine, right. Supine eliminates or reduces gravity for me. I can also put them on like a pillowcase or something like that to help them move a little better. And then for adduction, I'm going obviously sideline again, but now where's my leg? It's on the bottom, right? Or leg down, it's the underside leg. I'm just going to go through all the positions real quick on the floor just so that it makes sense in a second. So don't totally freak out yet. And again, my gravity reduced position, supine. It's neat. All right, internal and external rotation. Against gravity, I'm going to be in what position?
Short-seated.
Good. Short-seated. And actually for both of them, they're the same, right? And then for gravity reduced, we do supine. We just have them lay on their back and kind of turn their foot in and out. So let me change cameras here. I'm going to leave those up and just change my camera.
Mr. McKeever?
Yep.
If you can't go supine on external and internal, could you do?
Yeah, I could do any position I wanted at that point. I could do prone. And honestly, I'm going to be 100% honest. When I do internal and external rotation, like I was trying to think about this for a second. Like I could do long seated too if I really wanted to. Right, I could straighten the legs out and still do the rolling without having them lay supine. So like I was trying to think about that when you were mentioning that. I actually think I do long seating in the clinic when I do it. But it's not the technical proper way. And so for your boards, you would say supine is the technically proper way, right? But any position that just stops gravity from resisting them is okay. Again, when we get down into these here, it's, oh, I didn't want to do that. I wanted to draw around. When we get into these positions here, positioning, while important, the main goal is just reducing gravity. Yep. All right, so let me switch cameras. That should switch to my other one. Yeah. Why is that upside down? Okay. Because I put my camera upside down. How did I accomplish that? Let's fix that really quick. That's funny. Oh, you guys are going for a ride. There we go. Now it's upside right. So for manual muscle testing of the hip with flexion, right? I'm going to be seated. I'm going to be comfortable, and I tend to have them do the cross hands or hands on their hips, whatever works. We're going to bring it up. That is gravity dependent or gravity resistant. I'm lifting up, right? Stuff I'm looking for compensation wise. I'm looking for patients to do stuff like this, or grab a hold of the chair and lift up, right? Something to help them cheat. I just want to test your vestibular systems. That's all, guys. I see you got busy, right? So this position is here. For me to go and eliminate gravity, I'm going to move my chair out of the way. I'm going to lay on my side, move up some. And now in this position here, I'm going to do flexion this way. Because now in this position, gravity is reduced as much as possible. Gravity is more pulling me into adduction than it's pulling me into flexion or extension.
Mr. McKee,
Yes.
from the whiteboard to you, you're like tiny.
I'm sorry, what was that?
Could you switch the view from the whiteboard?
Oh, sure. So you want big picture?
Yeah, I can.
Okay, no problem. I left whiteboard up so I could leave the techniques up, but I can definitely bring, is that better?
Sorry.
No, I appreciate it. Yeah, I will take all the feedback you give me. So again, hip flexion manual muscle testing is here. You don't want to make me any bigger. I'm big enough. Don't talk about my weight. Anyway, hip flexion against gravity is here, right? That's okay. We're good. I can still walk you through it. So against gravity, you're going to be pushing down. To eliminate gravity, I'm going to tilt this just a little bit more. I'm going to go side lying on the ground. And I'm going to bring the leg up into flexion from your belly. Okay? So that is hip flexion manual muscle testing. For hip extension, I'm going to go into what posture again?
Prone.
Prone. So now I'm going to come here, right? I'm going to lay down. Now let's check my camera. I can see it good. And I'm going to extend the leg up, knee straight. I've almost got none. Oh God, that's so tight. Right? And the goal is to make sure I don't do one of these, or I'm trying to think what other, I've seen patients, oh, here. This was one I saw the last time I did it. That's not testing hip extension. So I want to lay prone, and I don't have a pillow. That's the only reason I'm up on my elbows, which probably limit. If I go down, I probably can, yeah, I can get a little bit more if I'm flat. And hold, push down, 5, 4, 3, 2, 1. Boom. For gravity reduced, I'm going sideline. And I'm going to go straight back. Now I cheated there a little bit. I've got to get a little bit better posture here. So straight back. Just remember that if I bend my knee here, though, that actually makes it harder for me, because I've actually then stretched out that quad and made it a little bit passively insufficient. So I want to keep it straight so I can get some good range. So that's flexion and extension. For AB and AD, right? I'm going to test my right leg for abduction. Oh, I can turn this way. That makes it better. There we go. You guys can see my nice little bruise on my shin. Yay. For abduction, I'm going to be here, right? And again, you saw her. She moved the leg back into extension before she did it to cheat. You don't have to do that. Just in this position is okay. I tend to find that bending that lower leg makes them feel more comfortable because they've got a little bit of base of support then. That is okay. And I prefer it that way because that gives me a little bit wider base of support, right? I don't feel like I'm teeter-tottering all over the place. My toes are going to be pointing straight forward. I'm going to come straight up. What are you looking for cheating here? This is the most common cheat you see. My toes are pointed up. At that point, I'm doing hip flexion, right? So toes pointed straight forward and up. Yes.
They could also roll the hip forward to cheat.
Yep, I could go here and use glute. Now that actually hurt. Getting old. So up. And there's abduction, right? For adduction, or for abduction again, staying with AB, gravity reduced, I'm just gonna lay on my back and try not to hit, I hit my head in the chair anyway. And I'm just gonna go out to the side and back, just like we did with that exercise. Right out to the side and back. All right, adduction. I'm gonna test my left leg just so I can say and I can still see you guys. She took this leg and held it up in the air and then brought this one up. I find that's a pain. That's way too much work. So what I have my patient do is take this leg and put it here, as if we're doing the 4-way hip. That gets it out of my way. And then I also have limited ability to cheat because this leg kind of keeps me from cheating, right? So I'm gonna bring the leg up, keep my toes pointed as forward as I can, and they're gonna push down. And this one probably is one that we don't have a ton of force on, but push down, 5, 4, 3, 2, 1. Boom. Okay, good. And then for gravity reduced, I'm not gonna hit my head this time. I'm gonna lay on my back. I'm gonna bring the leg in, right? So I'm gonna get this leg out of my way a little bit, start at neutral, bring the leg in. As long as I can get range of motion there, I've got a 2, we'll talk about 2+ and 2- again in a second. Internal, external rotation, I think. Come here, chair. Come here, get over here. All right. Internal, external rotation, they're gonna be seated. I prefer to have their foot off the ground again, but my chair's already here and I don't wanna raise it up any. Again, I give about 3 inches of clearance between the popliteal fossa and the back of the chair or the table that they're on. Right, so if I'm doing external rotation, I'm going to tell them, bring the foot up and in, don't let me push you down and out. So I'm coming here and I'm gonna be applying force that way. For internal rotation, you're just gonna do the opposite. They're gonna turn, I've got almost no internal rotation. Turn that foot up and out. Don't let me push you down and in. So I'm gonna apply force on the outside, the lateral aspect of the foot going that way. And then I get like, I think it was Anthony that asked or John. Honestly, I was thinking about how I test for gravity eliminated. And I remembered, I have the patients just sit like this. And I just have them turn their foot in this position here. Like I was really trying to think of how I had them do it. I just have them straighten their legs, and when I'm in the clinic, this is the cheater's way, so I guess don't do that. But that just made more sense because I didn't have to move my patient. Because I try to keep from moving my patient as much as possible because the more I move them, the tighter they'll get. This would technically be considered long sitting, yeah, technically, right? It's not pure long sitting because I'm not at 90, right? But technically this is long sitting. The book says, though, that you have them lay on their back and you either test for external rotation or test for internal rotation. External or internal. Again, in the 2 and the 1 position, cheating is not as much of an issue as it is for gravity or with gravity. So the positions make sense, mostly. Go back to my whiteboard. Oh, I gotta change cameras. I'm like, why are you looking at my hip? Back to the other camera. There we go. So when we are applying, so where we apply resistance. And remember, what levels do we apply resistance with?
3 and up.
3 and up, good. 3, 4, 5, right? Now 3 doesn't have to have resistance. If they get full range of motion, we'll go through those ranges again in a second. But 3 and up is where we're looking at resistance. For hip flexion, you're going to apply your resistance at the distal femur. So, or the other way of putting that is at the knee, right? The knee. So again, switch video. I'm going to apply it down here at the distal knee, pushing down. A full-on studio going here. For hip extension, where I'm applying resistance is, I just say just proximal to popliteal fossa. Or you could also say, again, distal posterior femur, right? I don't apply my range all the way out to the ankle. Even in athletes, I don't do that because I just don't like being that mean to people. For ab and adduction, right? So for abduction, I'm applying my force at the lateral epicondyle. And obviously for adduction, I'm applying it at the medial epicondyle. So I'm going to switch video here really quick again. So if I'm side lying and I'm lifting my leg up, I'm going to push it right here at that lateral epi. If I'm coming into adduction, I'm going to push it at the medial epi. And then for internal and external rotation, I usually apply my pressure, my force at the not mead, I don't want to say mead. Mead is not the word I'm looking for. I want to say kind of mid tibia is about where I put my pressure. So again, if I'm going into internal rotation, I'm going to come down here kind of, well, I guess mid lower leg would be the better term. Push that way. If I'm going into internal, I'm going to push that way. So kind of the mid lower leg, mid tibia is kind of where I put my force. You can go all the way down to the ankle. Just realized you can't see me moving. You can go all the way down to the ankle and pull on the ankle, but again, you've lengthened your force arm at that point. It's not very fun. So John, what were you talking about hamstring? Did I miss something there? I'm sorry.
No, it's okay. It was just more for like proximal to the palpable.
Yeah, for the like for the extension, yeah, hamstring would be a valid place to put it. Yep.
Okay, thank you.
Yeah, that'd be okay. As long as you're not like all the way up in kind of their butt crack pushing down, that doesn't work out very well. Right? Again, it's just try to make it as least awkward as possible. So how do those feel? Do those feel a little bit less intimidating at this point? I don't think they're as bad as you thought, right? And this is the reason I spend, I'm going to tell you guys right off the bat, I spend a ton of time on the hip because that way we can kind of blow through the rest of the joints a little easier. Because if we can get the hip, you can get the knee. Honestly, the knee's only got 2 motions. If you can get all the motions of the hip, you can get the knee. All right, so it's about 2:40. How about a break now? How do you feel? That's not like a plan? Yeah? Okay. So let me pause my recording. Okay, so we've gotten through kind of the minimus test, the range of motions, stuff like that. Let's just re-review. I'm going to bring back up the whiteboard. I'm going to wipe it really quick so we can just re-review the levels of minimus testing again, just so that we're 100% clear on it as mud. And we all have got that down pat. So we're talking about MMT grades. And these are the ones I specifically want you to know. So these are the ones that our clinics use. These are the ones that I want you guys to know. So we have 5, 4, 3, 2 plus, 2, 2 minus, 1, and 0. When we are testing a patient, what level do we start off at always testing the patient at? We always want to start testing them for what grade?
3.
3. Yes, this is our starting point. Right, we always want to give them the ability to have a normal range of motion against gravity. So in the case of using hip flexion as an example, we're always going to start testing them in short-seated position. So this 3 is range of motion full. Again, I'm going to asterisk that. I know full is what the book says. I would say more functional. FX is the abbreviation for function against gravity. Are we doing any resistance at the 3 level?
No.
Yeah, no resistance, right? And if you remember, G is the gravitational constant, so against gravity. I didn't have the chat brought up. That probably would have made sense because a lot of you replied and I didn't see it. That was brilliant of me. Good job, Mr. McKeever. You get a golf clap for that. So no resist, right? The only resistance at that point is gravity. So let me take that a step further. If they have a 3, can they have a fairly functional life? Meaning getting up, getting around, walking, talking, doing all their normal stuff.
Yeah, I think so.
Yeah, right? I mean, they're not going to be able to go out and like lift a bucket and stuff like that or whatever it may be. But yeah, that's a 3 is what we need to basically get around and do stuff. Anything above that is golden. Anything below that will impair function. So if you ever get a question on your boards that says, what manual muscle test would indicate an impairment in function, it would be anything less than a 3. Because anything less than a 3, we've got problems. They can't do anti-gravity. They're not able to do something like a eccentric activity. So that would be a big thing. Go away, Slack. All right. So if I have a 3, the next thing I'm going to test for is, are they a 4 or are they a 5 then? So that's if I have a 3. If I don't have a 3, do I have to test against resistance?
Yeah, you need resistance for 4 and 5.
Right, but I'm saying if they don't have a 3, they're not able to get, you know, if I'm doing hip flexion and I can't get any range of motion, I can't go against gravity, is there any point to try resistance? No. Yeah, right? So don't worry about it. If you have a patient's like, and they get like an inch off the ground and that's all they get, there's no reason to test resistance at that point because they're not going to resist you. So I'm not resisting. Wait, no, that was a little dark. Okay. So a 4 is all of the 3. So that means full range of motion against gravity plus moderate or submaximal resistance. Right, so resistance, I was going to use the ohm symbol, but I decided against it. Or they break. And what I mean by that is they get that full range of motion, you push down and you start pushing and then suddenly they drop. They've resisted you a little bit, but they've broke. That's a 4. Now, if you push them, as soon as you put that pressure on them, they drop. That wouldn't be a 4. They're not able to do any resistance at that point. But if you push and they're like, okay, I got it, and then they break, that's a 4. Again, a little bit of subjectivity to that. A 5 is all the level 3 abilities again. Technically all the level 4 as well, but all level 3s plus maximal resistance. For how long?
5 seconds.
5 seconds, right? So that would be, again, I'm going to lift my leg up. All right, Mr. McKeever, don't let me push you down. 5, 4, 3, 2, 1. Blast off. You can relax. Now, again, what happens if I get to a 3 and I break? Then I'm going back down. They're going to be a 4. It's always better to grade them a little on the conservative side. So if you're like, did he resist for a full 5 seconds, or was it really 4.5? Was it really 3.5? It's better at that point to go, oh, he's probably a 4, to give them room to improve, right? I mean, I'm willing to bet that, you know, most of us operate in the 4 range for the most part of our day. That's just kind of where we are at this, you know, not all of our muscles are going to be 5, especially if we test something like scapular adduction, or adduction away from the body. Probably we're going to test a lot of you that are only at a 4 for that.
So I have a question about how much pressure you give.
That was where I was going next. What is your question?
Basically, do you mean their resistance kind of like the amount of pressure, or do we challenge them?
So what was, I'm sorry, what was the last part? You broke up there at the last.
Do we have the same resistance, or do we challenge them?
You want to challenge them a little. So you want to apply your resistance in proportion. There's the word I'm looking for. In proportion to your patient. So I'm going to test you. That's okay. Riley was saying, you know, do we basically, how do we grade the amount of resistance we give them is what he's saying. And do we challenge them a little bit? So, do I, and I'm going to have to look into the feedback thing. I think it might be something with Zoom. How do I grade how much resistance I give them? I'm going to grade all of you a little differently, all right? I'm going to give John a little bit different resistance than I give Stephanie. It's got to be relevant to the patient, or congruent to the, not congruent, or proportional to the patient. I'm not going to test 78-year-old Millie the same I would test one of my previous students, Demetrius, who is a bodybuilder. Right? Stephanie's probably stronger than you, John. I'm just saying she is. I've seen those guns. I'm going to test Truman probably a little different than I might test Bianca. It's all going to be relevant to the patient. And how am I going to know that? Well, the first time I put my hands on a patient, you can usually tell that. So when you start testing a patient, you know, if you feel that you're putting way too much pressure on them, back off a little bit. It's okay to kind of back off a little bit if you think you're doing too much. It is a little bit subjective, like I said. So it's not 100% of an objective finding. You're going to have to gauge it on your patient. But you want to keep your resistance consistent visit to visit. So, you know, if I'm putting, you know, I don't know how to really gauge this, but if I'm putting 200 pounds of square inch force on John today, I want to use the same amount of force on Friday when I test them. I've got to kind of keep it consistent with it. This is why I said those force plates or those dynamometers are probably going to become more standard, because then you don't have to worry about how much force you put down. You just have to remember how much force they put against you. I think they're going to eventually become the kind of the gold standard. And they're becoming less and less expensive. So that's 3, 4, and 5. Those levels make sense. Ça va?
Yes.
Okay, cool.
I do have a question though.
Yep, no problem.
Why don't we grade non-gravity the same as we do with gravity? Like, why does it have to get all the 2s and the 1 is?
Why do we have the pluses and minuses when we get down there? Is that what you're asking?
Kind of, but why isn't it just all the same? Like,
Maybe.
like the 3, 4, and 5.
Yeah.
Why is it with gravity?
So why do we worry about gravity? Is that kind of where you're at?
No,
Or maybe
I think I'm just like, why it didn't hurt the way why isn't it?
Why do we maybe not use the same position? I'm lost as to where your question's going here. So, and it possibly could be me. And maybe it's just I'm just not grasping what you're asking.
I'm probably just asking like my question then.
Are you asking why we use resistance? Or are you looking for? I mean,
I think I'm just like why did they make so many numbers and it's not to do 3, 4, 5 for non-gravity?
yeah, I mean that's actually and that's a fair question, which is why I tend to think that, like I said, that those handheld dynamometers are going to become the standard. Because here's the deal: if we have those handheld dynamometers, we're not even going to have to. We're basically only going to have whatever the resistance, whatever that machine tells us, or a trace, and that's going to be it. Right? Then we're not going to have to worry about positioning so much. We're not going to have to worry about, are they in sideline, supine, with gravity, against gravity. It's just going to be how much force do they generate.
Okay.
And why do we do that this way? The best answer I could possibly give you is because that's the way we've always done it.
Okay.
And I don't have a better answer than that. I mean, there is research on this. Handheld, yeah, sure. So she asked, can I spell it? It's handheld dynamometer. The other thing it could be called is a handheld muscle force plate. I think it's the other term I've seen them use. I can send a link then so you can look at it then. Yeah. Yep. So, I mean, I understand where you're coming from, and I understand that this doesn't make sense. Why do we test this one in this position, and why do we test in this? And I think it's the best thing I say is probably due to, the way we've always done it and a little bit of research. There is research that shows these muscle grades do apply. And honestly, when we get into spinal cords next semester, we do use these, but most of the time in spinal cords, we're kind of down here in the 3 to the 2 range. We don't really care so much about the resistance levels because they're just trying to recover from a spinal cord. So I don't have a better answer than that, really. And let me think about it for a second, see if I can come up with a better answer for you. I understand what you're asking. I just don't have a good answer for it right now. All right, so I mean, the best answer I have right now is just because, and I don't want to use that as the answer. Now we go down here and we're at 2+. So with 2+, we have partial, again, range of motion against gravity. And when I say partial, I'm not talking like they got 85 degrees instead of 90. I'm talking like they've got like 15 degrees of motion when they should have had 90. They've got a little bit of motion. So again, if I'm doing the hip flexion, I'm out here, right? I'm like, I've got baby motion. I've got some partial range of motion against gravity, and I have full range of motion, gravity eliminated, so minus gravity. So that would be where I move them into sideline or supine or something to that effect. When we go to a 2, it's just full range of motion without gravity. Again, that's a G. A 2- is partial range of motion, no gravity. A 1 is that trace or a tickle, or I've heard it called trace, a tickle, quiver. means the muscle just fired but can't do much. And then the 0 is typically there is no movement whatsoever. There's nothing going on there. The muscle's not doing anything. So we always start at 3. Twitch, yeah, there we go. Twitch is the other word I was looking for. I appreciate it. I guess tickle's not the best term. We shouldn't be tickling our patients. That would be odd. Tickle monster's coming for you. It's in therapy. That just sounds weird. So anyway, so we always start. So let me get my other camera here real quick. Okay, so we always start, let's just say we're going to do hip flexion here. We always give the patient the chance to be a 3. So I say, okay, Mr. McKeever, we're going to go ahead and test your range of motion of your hip. So what I want you to do is I'm going to sit down beside me. If I was testing me, I can't be multiple people. So I'm going to show you. So you're going to lift your leg up like this, as far as you can get it up into the air. All right, go ahead and do that for me. All right, I completed my full range of motion. It would be like, I'm out, yeah. Some of you will still be ticklish when we do some of this stuff, but that's beside the point. So up and go, and down you go. Good job, Mr. McKeever. You're able to get full range of motion. I've got a 3. Now, if I'm here and you tell me to lift it, and I'm like, I've got baby range of motion. That sounds, my neighbors have got to be really wondering what I'm doing down here. If I've got that little baby range of motion, that means I've got partial range of motion against gravity. I now need to move myself into the gravity eliminated position. As long as I've got full range of motion, though, the next step is I'm going to add resistance. All right, so Mr. McKeever, I want you to go ahead and bring that leg up again like you had it. I'm going to put my hand out here at your knee. I'm going to push it down. Don't let me push you down. 5, 4, oh. Well, that's a 4 because I broke. A 5 would be up here. 5, 4, 3, 2, 1. Good job, Mr. McKeever. You're awesome. Thank you, Mr. McKeever. That was great. I really appreciate your physical therapy training. I'm talking to myself again. So let's say we were doing this hip flexion again, and I get that partial range. I don't get any, I only get like 10 to 15 degrees against gravity. What would be my gravity eliminated position again? Sideline. So that is a great question, John. So John asked, can we assume that if they have partial range against the gravity, they will score a 2 already? Pretty much. I mean, again, remember, we're talking about functional range of motion. So, you know, it's pretty likely that if we put them in sideline, like Truman and Stephanie just said, that they'll get a functional range of motion with gravity eliminated if they've gotten a little bit with gravity. So they'll at least be a 2, right? I mean, I've encountered sometimes where I put them in sideline and the problem is not strength then in sideline, it's they've got a contracture or something like that and they don't get full range. So that technically they're a 2-, but I still rate them a 2 or 2+ because I'm like, oh, they've got functional range. Like, so say I do this and I go sideline and instead of getting 120, I only get 90. I'm going to go, you know, close enough for me, right? That's close enough for government work is what I always say. So now you test me for a 3 and I get nothing. You're like, lift your leg up for me, Mr. McKeever. And I'm like, I can't do it. I'm so sad. Then you put me in sideline. I'm on sideline. Go ahead and move it now. Try it now, Mr. McKeever. And you're going to support them a little bit. You're going to take some of that weight off that leg so they don't have that gravity squishing those legs together. And I'm like, oh, I can do this now. So now I get full range of motion in sideline, but I have nothing against gravity. What am I rated now?
A 2?
A 2. Remember, I have full range. I have nothing here, but full here, that would be a 2. Good. 2+, Anthony, would be that I've got something a little bit here, and then I've got full here. Right? So now you lay me on my side, and I'm like, okay, I'm going to move my leg. And I'm like, Now I'm a what? Good, I got 2 minuses showing up in the chat. That's what I like to see.
Mr. McKee,
Yep.
for like the two for personal, the resistance scan, or is it us pushing again?
All right, so are you asking if 2+, do we add any resistance? Is that what you said? Because you broke up a little bit.
Yes, when it that means a little bit resistance, right?
Well, the resistance is just gravity. So we're not going to put any physical resistance against them. So with the 2+, when I'm here, 2+ goes exactly like this. Okay, lift your leg, Mr. McKeever. And I get a little bit of motion against gravity. So gravity is my resistance here. And then I go side lying and I'm like, okay, do it again. And now that gravity is eliminated, I'm like, oh yeah, I can do that now. Right, so gravity was my resistance. I had a little bit of motion against the gravity resistance, and then I got full range with no gravity.
So you would too.
That, yep.
Okay.
Now I'm laying here and I tell you, okay, Mr. McKeever, move your leg. And I'm like, I am Mr. McKeever. And you're in here in my inguinal area and you're like, ooh, I can feel iliacus firing a baby bit. But I'm not moving. Now what am I? 1, right? You got trace. You got something going on there. And then you're going here, you're like, okay, Mr. McKeever, firing. And I'm like, I am. And you've got nothing. That's a 0. And that is really, 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 really demoralizing to a patient. I'm going to tell you from experience, just because when I had my arm, it's really demoralizing when you're like, okay, bend your bicep. And I'm like, I am. And my arm's not doing anything. There's no contraction. It's really demoralizing. Because your brain is telling your arm to move, but nothing's happening. Right? Just imagine like tomorrow you go to the gym and you're doing bench press, and all of a sudden you get down here and you're telling your chest and your arms to fire, your triceps to fire, and nothing's happening. Right? You really legitimately feel helpless. I'm just using the bench press as an extreme example, but it really does feel helpless when you can't fire those muscles. Do the grades fairly make sense?
Yes.
Okay, good. I got Brooke saying yes, so that means if Brooke's got it, everyone else has it, right? I'm just kidding. All right, so let's switch. Let's clear this. I'm going to shut down the whiteboard, stop the share. All right, so now we're going to change gears and we're going to think about exercises. Because we're going to, first of all, we're going to go ahead and think about, so what kind of things could patients come see us for? They could have total hip replacements, could have hip fractures. There's all kinds of fun things they could be coming to see us for in the clinic. But we've got to start somewhere with exercises. So again, in that acute phase, our goal when we're in an acute phase of injury is we want to work on stability. And what kind of exercises did I say really work on stability?
Isometric.
Isometric.
Good, right? So we're going to start with those stability exercises. So what are some of those isometrics that we could do of the hip? What exercises could we do to help strengthen the hip?
Can you do like wall sits?
Okay, good, right? So many, good. Right, it's like so many. Heel slides, right? Here we go. Heel slides are a little bit more movement, right? That's a little bit more isotonic. So let's think like our quad. We could do flutes. I like flute sets. I haven't done flute sets yet before. Flute sets, quad sets. We could turn a pelvic tilt into exercise. Here's one thing I want to kind of clue in, that when people start thinking, I can't think of an exercise to work with my patient. You could. Side planks, good. When you can't think of an exercise to work with your patient, you can turn your manual muscle test into an exercise. Because let's think about it, right? My manual muscle test was lifting my leg up like this. How do I turn that into an isometric exercise? I give the patient a little bit of resistance so they can't lift, and they're going to push up into my hand. Right, if you hold everything, it becomes isometric. You're exactly right, Riley. So you can turn everything into an isometric exercise if there's no motion. I could also have the patient lay in prone and have them flex their hip because the mat's there, they're not going to be able to move, so it becomes an isometric. Again, we're going to stabilize that hip, get it nice and stable because you have to be stable before you can become mobile. That's the key thing. Just like motion is lotion, we've talked about in physical therapy, you have to be stable before you become mobile. And you have to think of, and like, I think about that in the standards of like a gymnast, right? So a gymnast works on a lot of their techniques, holding it and developing the skill of the technique before they start doing all the jumping all over the mat and doing flips and back flips and everything like that. They have to get the stability of the movement before they can get the mobility of the movement. Same thing happens when we have hip injuries. We have to work on kind of the stability before we work on the mobility. So now I've gotten through all my stable exercises. I'm good. My isometric, I'm out of kind of that acute phase. I'm maybe into the subacute, moving into that chronic phase. Can start adding some active assist. Maybe I get through that active assist. I'm now into active range of motion. So I'm now into my isotonic phase. Now, when I get into the isotonic phase, I have to think about what am I looking for? Am I looking for a concentric activity or am I looking for an eccentric activity? Or am I looking for an open chained activity or am I looking for a closed chained activity? All of those are going to strengthen me a little bit different. We use eccentric a lot more in function than we do concentric because eccentric allows us to get around in life. So we definitely want to have some eccentric activities going on, right? Working on my hip, what do you think the most basic functional movement I can work on in order to strengthen my hip? What is kind of one of the most functional activities we do on a daily basis that would work the hip?
Walking or marching.
Okay, walking, marching, right? I'm going to go a little bit, take a step back from that even.
Standing up.
Getting up, yeah. Standing up from the chair, right? So just standing up, well, squatting goes along with that, Anthony, so that's partially correct, right? So just standing up from a chair is our most basic hip exercise. So now with that, this is where it gets a little challenging. Is this a closed kinetic chain activity or an open kinetic chain activity? Okay, good, right? Would this be a eccentric or a concentric activity? So I see I saw the clue there. Joe kind of got into he figured me out, right? It's a both, right? Because even when I'm doing a stand-up, right, I'm firing my quads to straighten my knees, but I'm also slowing them down so I don't hyperextend, right? So I have control there. So I'm doing a little bit of both when I'm doing it. So let's talk about the proper procedure for standing up for a patient, because that's really important here. This is the most basic exercise we can work on. So I'm sitting in my chair. I've got my arms on my armrest. Now this ideally would not be a rolling chair, right? This is bad to work on a patient because this is not stable, right? If I move around, it can move actually this carpet's kind of getting it stuck. I need a mat down. What is the first step to standing up? What's the first thing I have to do?
Flexing your trunk, like.
Okay, I got gate belt. There we go. Diana got my trick. First step is putting a gate belt on a patient. Good job, Diana. You caught my trick. All right, so we got that. We got a gate belt on me, right? Hold on. Let's see. I don't know where my gate belt went. I don't know where my gate belt's at. It vanished. All right, I've got a gate belt on me. My gate belt's on. Click. All right, so I got a gate belt on. When we're doing it from a neurological standpoint, so I'm going to break it down. This is the sit to stand technique as far as it goes for your boards. Your first step, camera's over here. Step number one is scooching forward. Or as I call it, where I'm from, rutching. You're going to rutch yourself forward or slide forward. right? I want to get where my ischial tuberosities are out here towards the edge of the mat, or the edge of the chair, or the edge of the mat, or whatever I'm doing. Now, I heard the next step. Somebody said it, trunk flexion. So if I say trunk flexion, a patient doesn't understand that. So I break that down. Touch patient, yeah, before a block, we're definitely going to be doing that. We're not talking about pure blocking yet, that we're going to talk about in a second. So what I say is, okay, slide forward. The next step is nose over toes. So we're going to lean forward, get my nose over my toes. Now, once I get here, there's a technical point at that point that is called the point of lightness. So the point of lightness is when a patient's out at the edge of the chair and their nose is over their toes. What the point of lightness is at this point, my ischial tuberosities are starting to lift off the chair. Right? So step by step, scooch forward, nose over toes, point of lightness. Now, knee extension combined with hip extension, followed by trunk extension. So I'm going to start straightening my knees. My knees are going to start straightening. My hips are starting to straighten. As my hips start to straighten, my back starts to straighten out. So it all starts at the knees first and then works its way kind of up the body. So step by step again, right in here, scooch forward, good. Nose over toes, good. Point of lightness, knee extension, hip extension, trunk extension.
So is the point of lightness basically when you have no weight on your ischial tuberosities?
Yes, you are 100% on that. You got that. It's the point where, so what I like to think about the point of lightness out here is, if I would keep leaning forward, what would happen? I'd fall out of the chair, right? So once those ischial tubes are up, that's the point where I could kind of slide right out of the chair if I needed to. That would also be a good point when we would do a sliding board and slide them across to transfer them, because the ischial tubes aren't digging into the chair anymore.
So you said hip and knee and then nose over toes, and that's it to get to like the point of lightness?
Yeah, so slide forward, nose over toes, I'm at my point of lightness. And then from there again, it's just a movement through a cycle, right? Knee extension, hip extension, trunk extension, I'm upright. That is the technical method of standing up. And now that's without hands. You can use hands if you need them, right? I could be out here at the nose over toes and push up if I need my arms. But if we use our arms, we're not purely working the hips. So we want to make sure that if we're just doing hip exercises, the arms are kind of either on their legs or wherever you put them. I tend to have my patients cross their arms across their chest, because that way they can't cheat. Does that make sense for the kind of steps to sit to stand? I know that's a really kind of in-depth thought process, or not in-depth thought process, but in-depth, we don't even think about it. We just do it. It is a lot harder for a patient to stand up if I'm way back here. Like, if I'm not using my arm, I'm going to try not to use my arm. I can stand up from here, but it's a lot of work when my butt's way back in the chair.
I guess my question is, when is it pertinent to use point of lightness? Like, when are we using this?
Well, here's the deal. The only reason I'm hitting that is because I know that's a board question. I know what they'll say on your boards. They'll probably ask you a question where they say, you know, what are the steps to standing up from a chair? And you have to make sure that you hit that point of lightness, because that's for whatever reason, from a not for whatever reason. From a neurological standpoint, that's an important part, because that is a control point. This is the part where things can go south really easy. So this, from a neurological standpoint, that is a determination of what control the patient has. Can they return from point of lightness back to sitting? can they go to point of lightness and not fall out of the chair? Does that make sense? Just in charge of the board, can't talk to them. I'm in charge of the board. No, I'm just joking. So the main thing I just want you to know is I want you to know that's part of it, Riley. And here's the deal. When you're teaching a patient, you're not going to be like, okay, slide forward, nose over toes, point of lightness. The patient's not going to have an idea what point of lightness is, right? What I do say is, okay, get your nose over toes. Do you feel your bottom starting to pick up? Yep, I feel my bottom. All right, straighten those knees, straighten those hips, straighten that back. Right? Does that help clear it up a little bit? I don't know if that'd be true. I'll take your word for that, but I don't know if they'd be more rational or less rational. There'd be more questions about chipmunks and aliens. All right, so now let's do the reverse. So now I'm going from stand up to sit down. What's the first thing I need to know about before I sit down?
Genuflect, bend your knees.
Okay, bend my knees. Okay, before I even bend my knees.
You need to know where your seat is.
Yes, there we go. Good, right? So I need to scoot back until I feel that chair against the back of my legs. Because that's the safest. And again, remember, we're not talking about, Riley and Diana sitting down. We're talking about little Millie who doesn't have all the control you guys have. So, okay, do you feel that chair against the back of your legs? Yeah, I do. I got it back there. Okay, Millie. So now, when we sit down, we want to make sure that we sit deep, right? We don't want to sit like out here. So we'll tell them, okay, you're going to kind of flex your trunk, get your butt going backwards. Sit down nice and deep, bend the knees and down. The main part of sitting down is control. So if you have a patient that you go to sit down, they're just kind of like flop. Nope, we need to stand back up, Millie. We need to work on that control. Because if she flops like that and she's 75 years old, she can actually get a compression fracture of the spine. So we want to make sure she's working an exercise that she can't injure herself with. Last thing we want to do is break her tailbone sitting down in a chair. I mean, we've all sat down on something that's not quite as soft as we thought it was. I did that. It was about 2 years ago. I was sitting down. I thought I was sitting down in the bed at this one hotel I was in. I'm like, oh, that looks comfy. And I kind of did flop down, and like the mattress was like that thick. And then there was a wood board underneath it. I was like, crunch. Oh, okay, that hurt. I did not control my sit. We've got to control our sits when we're doing it. Now, let's add a kind of caveat to that to help with control. If the patient has armrests and they're weak on control, once I feel that chair against the back of my legs, I want to at least take one of my hands and find the armrest so that they can use that if they need that, help slow them down. Ideally, if we're just working pure hip activities, we don't want them to do that. But if they're having trouble with that eccentric lowering, they can use that hand to help them lower themselves down. They can use two hands if they're really weak, right? But we want to slowly build that. So a progression may be starting with both hands. Okay, do you feel that chair? Okay, lower yourself down. Good. All right, let's stand up one more time, Mr. McKeever. Good, up. Now let's not use your right hand and only use your left hand this time. All right, good. And then I can progress to no hands. So that gives me progression. But that is a really, really good closed kinetic chain activity. I'm beating that into your heads because there might be a question on maybe next semester on one of Dr. Reskin's labs that asks about a good closed kinetic chain activity for hip extension and knee extension. That would just be a sit to stand. Does the sit to stand technique make sense? I know it's a lot more than you've ever thought about sit to stand, but it's kind of, there's a neurological reason for it. Okay. So we've got sit to stands down. Great. Now, like Anthony said, well, maybe now we're doing that really well. So now we can move to squats. Squats would be a progression of sit to stands because now I'm not going to actually sit down. I'm only coming partially and coming back up. That would be a progression. We could also do something like a leg press. That would be a progression. What kind of, let's say I have a patient that doesn't do very well with standing up, but they're really solid sitting down. We talked about for hip flexion, they could march, right? Boom, boom. How about for hip abduction and adduction? What could we do?
Swing the leg out.
Okay, swing the leg out and swing the leg in. Good, right? How about if we wanted to add something with resistance?
You could put a resistance band around their legs.
Good, right? So I can get my good old TheraBand out here. And I can tie it around my legs. Make myself a good solid knot so I don't read it. And then I can do abduction, right? I can work that. What if I wanted to work abduction? What could I put between my legs to work, or I'm sorry, adduction? What if I wanted to work adduction? What could I put there? I saw, oh, there's a ball or a pillow, good, right? Or I can even have them put their own hands and do kind of isometric against their hands, right? That's still strengthening. So that's working my ab and ad. Internal and external rotation are a little bit harder. Joe's thigh master, exactly. Thigh masters are great. But watch this. If I slide this TheraBand down here, now I can do internal rotation, right? It's a little harder, but I can do it. There is a technique for external rotation, but I don't like it, where you kind of cross the legs over. If I'm doing external rotation work, I usually am going to do manual resistance for them. The other thing you can do is you can stand on the TheraBand and work it. Just work it, like they said in the song, right? What
about putting them in a pool? Does that add resistance or not?
Yep, I was going to talk about lower impact. That's an excellent idea, right? The pool's going to do two things. It's going to reduce gravitational resistance, but it's going to add fluido resistance, right? It's going to add the water as a resistance. So for sure, right? We're going to actually do a whole class on aquatherapy towards the end of the semester. And maybe if we still can, we'll try see if the pools are open for allowing groups yet. I don't know if they will be or not. If not, we may hit that this semester. We did that with the last group. But yeah, so the pool is going to add a certain amount of fluid resistance, right? But it's going to reduce my gravitational constant. So it reduces my weight bearing, which is good, especially for a patient that might be a total hip replacement. The aquatherapy is a great way to work with them because they don't feel like they're going to fall as much. And the other thing is, if they do fall in the pool, it's a lot less traumatic, right? They just kind of fall in the water and hopefully they don't drown. That'd be a good thing. That's where you come in. So there are tons of things we could do. Now, let's add kind of weights. We can do cuff weights, right? We can put cuff weights down at the ankle to increase resistance. Are they really picky about having like 50 people there though? That's the problem. I try to do it in my apartment complex and they got really testy with me. So maybe we'll think about that, Riley. We may think about that depending upon what it's like. I can add cuff weights. Remember though, the further down my force arm I put those cuff weights, the more difficult, right? What other kind of weights can I add? Well, if you've got a cable machine, cable machines are great resistance. I like using cable machines more than I like adding weights because a cable machine, if I have a cable machine and I'm working internal rotation and I've got the cable kind of around my ankle, it works both the concentric action and I also have to slow it down for the eccentric action. which is why a lot of clinics, and I don't know if you guys have noticed this, if you were on kind of observations, a lot of the clinics have more type Nautilus cable machines than they have just dumbbells and barbells and bench presses and stuff like that, because it adds that kind of that eccentric control as well. There's not a ton of exercises for the hip where we're going to directly put a barbell across the legs and lift it up, right? But let's take it to a gym perspective. I'm going to tilt this up some so I can see my face because it's kind of bugging me, the joints in my belly. Let's take it to a gym perspective for those of you that go to the gym. What type of exercises do you do at the gym when you're doing with either a barbell, dumbbells, however you do it, that you're working your hips?
Or like the Bulgarian split squats one?
What was that? I'm sorry.
Like the Bulgarian split squats, is that?
Okay, well, that'd be one. Yep, I know what that is. I just have never done it, but yes. Hip thrust, good. Deadlifts, barbell hip thrust, right? Just general squats with the weight back there, right? So here's the deal is you guys don't realize this, but you know, you may not have thought this, but you've been doing physical therapy the whole time you've been at the gym. You just didn't think the reason why. Cable leg extensions, good, right? So anything that I'm doing that. So I can also do kind of the squats where I have my heels off the edge of a, like a step. When I come down and I drop down. Get butterflies are there. Lunges, good, right? I can have 2 dumbbells and be doing lunges. So all of those are valid exercises, right? I could even have the dumbbells in the back of my neck, right? Clean and jerks technically do work a little bit of the hips, but not as much. Single leg squat, sure, right? But remember, whenever we go single leg, they have to make sure the patient has what first? Other than
Stability?
Yeah, agility and functional balance, yeah. Because it's not gonna be good if we're having them do a single leg squat and they're like, oh my God, I'm gonna fall. Right? Wanna make sure they have that. You can even do squats where their leg is up on the chair. So I can put my leg up on the chair here. If I wanna work this leg really kind of eccentrically, I can bring that leg up so I don't bend as much when I'm doing stuff. So to that kind of thought process, let me show you a really good resource. Switch video real quick. Let me bring that resource up. It's probably one of my favorite resources on the internet. And share screen. So probably some of you have seen the site. If you haven't, I'm sorry, it's a great site. It's exrx.net. So this site has all kinds of things on it. Some of it I don't agree with. So there are some things on here that are kind of, not questionable is not the term, they're just not always the best type stuff, right? But what I really like on this site is this. I can click on exercise directory and I have got exercises for pretty much everything. So let's look at hip flexors. So we go to hips, we go to flexors. Now that I'm in here, I have everything. I have cable exercises. I have lever exercises. I have weights. I have body weight exercises, suspension, and I even come down here and I have stretches. So this site to me is really, really useful. Had any of you seen this site before?
No, I haven't.
So it's a phenomenal site. So I can go and go, hey, how about let's do a standing leg raise with cables. So I can come in here, and not only do I have description and how to do it, but a lot of them have videos to go along with it. And that can be really good in working with it. And it talks about the muscles that are working. And then if you click on the muscles, watch this. Oh my gosh, look at that. We got origin and insertion, right? We got its other names. We got all kinds of things that it does. We got a hip flexion. It does a little bit of rotation at the spine. Right? It's like, shut the front door, right? So this is exrx.net. I highly recommend bookmarking this. I keep it on my phone. I actually have it bookmarked in Safari on my phone because there are some times where even I can't think of an exercise, and this can give me a good exercise for it. So like, let's say we're going back here and we want to work the external rotators, right? There's cable exercises. So let's do lying hip external rotation. You go in here and look, we've got exercises for the cable machine. Right now, there's not always going to be exercises for everything, right? There's not really a, I think like a weighted exercise you could do with external rotators. Let's see what this lever exercise is. So it says it's new. Well, that looks funky. I never would have thought of using that machine like that. But that makes sense, right? That's the hip adduction machine, and they're just converting it into an external and internal rotation machine. I certainly can, not a problem. So, and we know Joe does this every day, but hey, I mean, now he's got new exercise he can do with this machine. Make eye contact with someone now, yeah. So there are all kinds of great, I really like this site. It helps me with a lot of things. I can, come in here and be like, oh, well, let's work on quads. What can I do with quads? Man, God, there's more exercise here with quads than I know what to do with. Right? Oh, maybe I want to do a Smith, right? So a Smith machine. So I can do a rear lunge on a Smith. I go in here and I've got a rear lunge on a Smith machine for it. We can even use this to our advantage because maybe you want to give the patient a couple exercises to do at home or at the gym. We can use this as a resource because one thing patients like is videos, right? Do they have isometrics? I can't remember if they had isometrics on here. Weighted, Smith, squat. I don't think they have isometrics on here per se that I know of, unless it's over here. Yeah, no true isometrics. But let's say I wanted to learn how to stretch the quads. I can click on kneeling stretch, and it gives me a stretch to stretch my quads out. So there's lots of stuff that you guys can do with this simple site. And this is really beneficial, I think, from not only a physical therapist assistant standpoint, but some of you may go, I'm kind of getting bored at the gym. You could go in here and develop a full exercise routine that's different than what you're doing now, and maybe change up your exercise routine a bit. So I really, really, really like this site for that. And again, one of my favorite parts about the whole thing is I can actually click on the muscles and it'll give me kind of an insight view into the muscles. So I hope this site's kind of useful to you guys. It was really useful to me, and this is before this was all cool and colored. It used to be in black and white. But there's a lot of stuff on this site. The weight loss stuff I don't completely agree with. There's some of that on there that's kind of questionable. There's other exercise info that's in there. Here's all kinds of stuff like preparing it. There's the SAID principle. We're going to talk about all that stuff. But all this stuff is actually pretty cool. I'm really happy with the company that does this site is really kind of out there and does some good stuff. There is a muscle directory. There's articulations in here. So maybe you forgot what hip flexion looks like. It talks about what muscles do the hip flexion. There's a little picture of hip flexion. So there's a little bit of everything. There's nothing on goniometry or anything in here. Talks about what happens if they're weak, if you have abdominal weakness, if you have hamstring weakness. There's all kinds of stuff like that in here. It's a really good site. Exactly. People be like, where did you learn that stuff? Yeah, we're gonna actually go through extra stretches in the lab for sure, Amanda. Yep. That's like I said, we're gonna have one day where we kind of go through stretching the whole range of motion and stretching the whole body. Well, not the whole body, but you get what I'm getting at. Because we're not gonna stretch the whole body, that would be weird. But yeah, so this is just, it's a really useful site. So I wanted to share that with you. This is about where I start sharing that activity. But I will, let me quick post that before Riley gets mad at me for not posting it, or anyone else does. I can post that really quick. Takes me 2 seconds. I'll put that in the lab section. Item. No, I want to do a, not file, I wanted to do item. There we go. I put it in there for you. So it should show up in a few minutes. All right. Why is it not saving? Oh, because I didn't click save. That would make sense, Mr. McKeever. All right. So it's 3:53. Let's talk a little bit about SOAP notes, and then we'll talk a little bit about the test, and I'll let you guys out of here. So let me bring up a whiteboard again and clear the whiteboard out if I don't have it already cleared out. Actually, let me bring up a fresh blank Word document, because that would be better than the whiteboard right now. Let's do new blank document. There we go. Because that way I can type and it looks a little bit cleaner than my handwriting. So share screen. We have our Word document brought up. Let me bring my chat back up. Let's bring this back up. All right, so I'm gonna make my font a little bit bigger so everyone can see it. All right, so let's just run through, let's say that we had a patient, and we'll go up here. Let's go that we have a 65-year-old female patient, status post, right total hip replacement 2 weeks ago. So that's our patient. That's who we have. Let me get a little bit bigger now. Let's go up to an 18 font. So that's who we have. So we have little Millie.
Will they tell approach they have, like, your answer?
Yep, that was exactly what I was going to put on here. So let's say she's a posterior approach. So she's a posterior total hip replacement. So subjective. What kind of stuff are we going to put in subjective again?
Her feelings and thoughts.
Good, right? Stuff that she says to us, her feelings and thoughts. So I'm going to kind of do my little generic way of doing this, and we'll talk through it. I just lost my total train of thought of what I was typing here. I'm going to type out. I should just type everything out rather than. I want to change this a little bit so I can write it. Okay, so we got a basic subjective here. So let's look at it. So patient presents PT today and gives verbal informed consent to treatment. I always put my consent in the subjective, that she has given me consent, because that way no patient can come back to me and say, well, I didn't want to do the treatment and you made me do the treatment. I always kind of cover my butt and tell them, put in my note that the patient gave me consent. If she was in a coma, I would put that patient gave implied consent due to medical status, because implied consent means she's in the hospital, it's for her own good. But she's not, she gave us verbally informed consent. So patient reports, so with pain, we have to indicate location, right? We have to indicate type, pre and post treatment pain. So if, we'll talk about that in a second. Great question, Anthony. So I'm actually going to hit that in a second here. You guys are getting scary that you're reading my mind. Kind of stop that. It's scaring me. So burning, stinging pain. That's what it feels like. It's free real estate. Exactly. You guys live in my mind all day long. If you were to see this on a subjective, would you be able to go exactly to where that pain is on the next treatment?
No.
Did you say no or yes?
No.
Why not? I'm saying, would you be able to locate it is what I'm getting at.
Yes.
Yeah, right, because it's pretty, if I change this and just instead say, right hip, that's not specific enough, right? Because the hip's pretty big. If I put at incision site, okay, that's a little better, but I tend to use my bony landmarks when I'm describing where my pain is. You know, so right hip, I could also maybe instead of it being at the ischial tuberosity, it's at from the PSIS to ischial tuberosity along incision site. That would be okay too. That's just a little bit more wordy, right? So Anthony asked, wouldn't the 3 out of 10 be subjective? No, because the patient is still reporting it. We'll talk about what we would put in assessment in a second, but we still would put what they reported to us in subjective. If the patient said it was, maybe they came in and said, post-treatment, less stingy. I've had a patient say something like that to me. Okay, great, put that in the post-treatment, right? And I'm putting less stingy in quotes because that's what they said. If you saw burning and stinging pain, what do you know about that type of pain?
Nerves.
Right, could be it's nerves. Or the other thing it could also indicate is what's happening at that incision site. They've got what?
Infection.
Infection or inflammation. Yeah. Right, so that tells us probably a good idea to look at that incision. Now, that brings up a good point because Anthony led right into it. What if when I look at the incision, I see that there's inflammation and possible signs of infection? Where would that go?
You need to inform the main doctor and also pediatric.
Okay, so we got two different opinions here. And so I'm going to say that neither of those are, so you're right, we need to tell the PT right away or the doc right away. That's the main thing, right? But if we're documenting it, it depends upon your clinic where you're going to put that. If we are doing wound care, that would go in objective because it's an objective finding we're seeing. I know it seems weird because it's like, well, you're really assessing the wound, Mr. McKeever. Yes and no, because wound care is an objective treatment plan, right? If I'm not seeing this patient, I'm not seeing Millie for wound care, I probably would put it, right? You discovered it, so it goes in, all right. If I'm not seeing her for wound care, I may put that in assessment and I'm going to put in plan that I talked to the PT about it. But let's just say that her wound's okay. She's not having any problems, right? I may still, in objective, come down here and go, wound site appears clean and unremarkable. If I say wound site appears clean and unremarkable, that just basically means that the wound looks normal. Again, that's something I use when I'm not doing true wound care. Unremarkable is one of my favorite phrases. Unremarkable means there's nothing that I need to comment on about it. It just is what it is. It's a wound. It's there. It looks like a wound, right? If I'm doing, we're going to talk about in 5th semester, if I'm doing wound care, I've got to be a lot more specific than that. I've got to describe what the wound looks like, what's going on with the skin, what's going on with the skin around the wound. But in this case, the patient's just coming in for outpatient care. We're going to take a look at the wound, make sure the wound's okay, and move on with life. So when I'm doing a note, I break my notes down a little bit. So I'm still in O. Let's see, can I tab? I break my overall notes down into a couple different sections. Yeah, normal range. Yeah, that would be a good way of putting it. I break my notes down, if I don't have a flow sheet, into stuff like this. So I'll note my transfers, I'll note my gait or ambulation. You can put ambulation there. I usually put gait. And then I'm going to put my thorax, because I'm looking at what I saw, what happened during treatment, right? So let's say we worked a little bit on transfers because maybe she came in a wheelchair. So we worked on transfers. So we did so if you saw that on a note, what would that tell you?
Minimal assistance.
Okay, so minimal assist meaning patient did most of the work. Good. How many transfers did we work on?
3 transfers, and there's only 1 person assisting.
Good, exactly, right? So this little sign in the middle here that I put basically means I went from sit to stand and then back to sit, then sit to stand, then back to sit, right? So that means I went both ways. This means I did 3 reps of it. This means it was only me there, and then she did most of the work, right? Min assist, she did 25, I did 25% or less of the work. And again, Dr. Sokel should be going over those with you if she hasn't already soon. The difference between min assist, max assist, and all that. But this just tells me what I did with the patient. So I worked a little bit from her. Now I would ideally also put, why am I writing with the marker? Old habits die hard. Right? I would ideally put from wheelchair or from fixed armchair, something to that effect. Just so that I indicate what I did it from, right? So what kind of assistive device is Millie going to use? Just make some, what are we going to use? Who has an idea? Want to use standard walker, rolling walker? What do we want?
Standard walker.
All right, we'll use standard walker. Okay, so we know she's using a standard walker. I'm just putting that down there so I know it. So patient. Okay, so patient ambulated about 75 foot times 4 with standard walker, min assist times 1 with 2-minute rest sessions between reps. So this is kind of a standard thing you'd note in the note. So what this is saying is, how far did the patient walk? Well, they walked 75 feet, but they did it how many times?
4.
4 times. Yeah, so what that's saying is, we got up, we walked 75 feet, she sat down. We got up, we walked 75 feet, she sat down. And we did that 4 times. If that 4 was instead a clear, if the 4 instead said times 1, that just means she got up once, walked 75 feet, and that's all we walked, right? Let's say I walked 75 feet, turned around and walked 75 feet back, but didn't stop. What would that be? That would, yeah, that would mean that I'd walked 150 feet. Exactly. Just because we turn around, that doesn't make it a second rep. The total distance I walked is in one go is what I'm going to document. So if I walk all the way out 75 feet and I walk 75 feet back and I never take a break, that would be 150 feet times 1 because I walked in one go. But in this case, what this would be like is I'd set up a chair 75 feet away from her where she's at in the clinic, and she'd get up from her chair. We'd walk 75 feet over to that chair. She'd sit down. She'd take a 2-minute break. She'd get back up. We'd walk 75 feet back this way. She'd sit down. She'd take a break. We'd do that 4 times. Does that make sense? And again, the min assist just means I probably am helping her with stuff. I would probably indicate what I helped her with. So I might say with verbal cueing. I know what I forgot on this, by the way. I forgot something. Or gait pattern. I totally forgot to put my gait pattern in here. If I've got a standard walker, I've got to have a gait pattern. So again, we haven't talked about these yet with Dr. Sokel, but standard walker, total hip replacement. She probably is walking mod 3 or 3-1. And you'll talk about that with Dr. Sokel if you haven't yet. It's just a type of gait pattern that we use with the standard walker. And what that means is she's taking the walking with the walker with that injured leg. So we got the gait pattern down, what she did, what the assist. I gave her verbal cueing, which is probably where some of my min assist came, to make sure she's staying with her pattern. Have I lost anybody yet? We doing okay?
No.
Okay. So now we're going to talk about Therex. So let's put a bunch of different exercises down here. And what else do I want to do? Let's do ankle pumps. She's got a risk for DVTs. All right, so I put a bunch of exercises down. Is that enough? Can I just leave it that way? No, why not, John?
We need like if you have resistance, that's something.
Good, right? We need resistance. We need if there's any sets and reps. We need everything like that. So we'll go up here. We'll say she did glute sets 3 times or 2 times 15 with 2-second hold. The same thing for quad sets. Theoretically, I could actually put glute sets. In this case, if I put glute sets, quad sets, ham sets, I could get those out and just say that I did them all together. I did all those exercises together. So she did all of those glute sets, quad sets, ham sets, bilaterally, meaning both legs. She did 2 sets of 15 reps with a 2-second hold. With isometrics, there's not going to be weight. That's a good question. So Diane asked how she got therapy in O in a hospital setting. Depends upon the setting, or not the setting, but depends upon the clinic. Because one of the hospitals I work in, you're exactly right. They would put in here, transported to therapy via wheelchair with nursing, right? And then I also worked in one of the hospitals I worked at in Pennsylvania that had to be in subjective because I have no idea because they said so. That's the only reason I had for that one. Technically, it's an objective finding, right? But they wanted in subjective. And that's just one of those ones where you throw your hands in the air and just don't care. And just go, okay, I'll put it wherever you tell me to put it.
So and like when we don't know where to put it at, can we just ask like the rehab director?
Yep, or your PT, right? Hey, where do you put your transport? And likelihood, honestly, they'll be like, huh, I never thought about putting that in my notes. I've had that before too. I went into, so she asked, how they got the therapy, Riley. So how, who brought them to therapy? What happened? How did they get there in the hospital? Where do you put that? Because that's kind of important, right? If she walked to therapy, that would be important to note. But it just depends upon the clinic. I'm trying to think for myself. I usually include that in the subjective until I'm told differently, just because that was my main hospital I worked at in Pennsylvania and they wanted it in subjective. I think it's because they wanted more stuff in subjective so it looked like it was busy and Medicare would stop reading it, if you want me to be 100% honest. But yeah. So let's go back down here. So she's doing hip abduction slides. She couldn't do those too much. And here she did 1 set of 10. Oh, I went too far. So now we've got a couple things here, right? So we've got a bunch of the exercises. They all have sets and reps, right? I guess I should put a weight on the hip abduction slides just in case. So 0 pounds. Can't really do weights with ankle pumps, so I'm not really worried about that. So if you saw that as a clinician, what would your eye be drawn to? Good, pain, right? That asterisk says when she did hip abduction slides, she had pain, right? Okay, good. So you know that in your mind, you're going, okay, I got to pay attention to that. When she does the abduction, she might have an increase in pain. For the rest of it, she's not doing any weight, right? So we know that as well. And we also notice that the ankle pump, she's pretty good at. If she's doing 2 sets of 25, does she need to do ankle pumps in therapy anymore?
No.
No, right? What should we do to that? We should discontinue it or progress it. Good, we could progress it, sure. Discontinue it, and where would I send it to probably?
At home.
Yeah, her home program, exactly. So we're gonna use that in the plan actually. Because she's doing 50 of them. She probably doesn't need to do those in therapy. I'm just saying she should be doing them on her own. So let's go down here to assessment. Now, assessment, part of it's going to be what we've seen from a previous note. We don't have a previous note to go off of here. So we're just going to kind of have to wing it a little bit here, right? And again, I told you, patient. So I'm going to tell you, I use this quite frequently. I want to get rid of that second page. I use this phrase quite frequently when I write notes, and Dr. Avreskin yells at me. I'm just telling you. And her main problem is that this section here is kind of vague. And I agree with her. But this is not all that I put in my assessment. I put this in all of my assessments for one reason. And that reason is this validates my continued treatment. Because what I'm saying is she hasn't reached her goals yet and she would benefit from more therapy. So that being said, if you're going to use something like this, I would highly recommend modifying this beginning part to indicate how she tolerated the treatment well, or what was good about the treatment. I will continue to use this because Dr. Avreskin's not my boss. And I've used this for years, like years, and I, knock on wood, wherever I'm in, it's helped me keep from getting audited. Just because they look at this and go, oh, well, the patient was able to do their treatment and they're not reaching their goals yet. Now, that's not all I put in my assessment, but that I put in every assessment because that's been ingrained in me from the hospital that I worked in Pennsylvania. They wanted that in all of our assessments. So that's just kind of my generic thing I put in all of my stuff. I'm not saying it's right or wrong. I do agree with her that that first phrase is a little bit vague and probably could be worded better. So if you're writing a note for her, I wouldn't put that in there unless you want that note thrown back at you and for her to her head to spin around and start spewing pea soup at you. And I'm just joking. She wouldn't do that. What can we put in assessment? What do we have here that is a definite thing we could put in assessment? What has changed?
The post-treatment thingy.
Good, right? So noted reduction. So I'm going to give you that phrase noted. I like using noted because it means I noted it. I saw it. It is my subjective, right? If I say patient reports less pain after treatment, that is a subjective finding because patient reports means the patient said it. But because the patient said it, and I put that in my subjective, I can note that the pain is decreased post-treatment. Except with hip abduction slides at. So what would EROM mean? Does anyone know what EROM means? Yep, that's what you're right on the right side, John. What's EROM mean? So I didn't cover that one yet.
The end range of motion.
End range of motion, good, right? Some clinics use it, some clinics don't. Most of the clinics I've been in have used EROM as kind of, where they're going to put the, like when they talk about end feel, they'll put EROM end feel or something like that. I could just also put at end of motion, stuff like that, whatever it is. I'm just noting that with those hip abduction slides, her pain went up a little bit. Again, we're not going to put any numbers in assessment. So we're not going to go any numbers here. It's just going to be what happened. If they met any goals, we would put a goal down here. Like if they met maybe, she was supposed to walk 75 feet and patient achieved short-term goal number 1 today with ambulation. So that's also an assessment. The patient has achieved it, right? We've noted that they've achieved. Could put noted achievement of short-term goal number 1. What you're putting is that something is indicated at the end of it. If you noted that she walked with, maybe she walked with a Trendelenburg gait last session and today she didn't, noted reduction in Trendelenburg sign during gait today. You could put that in there. Again, we don't have a previous note, so I'm just putting some things I could put in there. Star, yeah. So star, that's a good question. I appreciate the questions. A star after the reps indicates they had pain during the activity. So I could put it anywhere. Like I could put a star behind glute sets, and that would indicate when she did glute sets, she had pain. I'm not doing that. And then this 0 pounds indicates I have no weight on her, right? And that's going to come into play when I'm going to talk about my plan here. That's why I added that in there. Did I misspell Trendelenburg? Oh, it wants me to capitalize. Of course it does. Stupid word. Okay, so again, with plan, the number one thing you'll see is continue plan of care as per PT or something stupid like that. It's okay, but you really want to get a little bit, yep, there we go. So Diana asked, does plan of care talk about progression of HEP? For sure. So in this case, in my plan of care, or my plan, what I'm going to say is DC ankle pumps to HEP next visit. So that means that next time she comes in, we're not going to do the ankle pumps. I'm going to review them with her, and we're going to put them on her home exercise program. And also say increase Hip, not hip abduction, marching. So now I'm adding a 1 pound cuff weight to the next session. What else do I have to put in the plan? Because what did I note in my HEP over here? I noted this. Short-term goal number 1 is reached. What do I have to do then? What does the PT have to do? What's that?
Progress to the next goal.
Yeah, right. So number 1, if they achieve a goal, the PT has to go in and update the goal, right? So I can put something like this: have PT reassess short-term goal number 1 for additional progress. Meaning maybe we'll discontinue, we'll say she achieved short-term goal number 1, but now he'll create a new goal that is walk 150 feet, right? So that she can continue to progress. Well, actually, so I'm gonna add those in next, Diana. So oh God, you guys are just scary. Get out of my head. Diana's like asking about vitals. I'm like, oh. So that's a fairly simple note. One of the things I note here, so Diane asked about vitals. Vitals would go in here in O, because vitals are an objective finding. And you would have to put whether you achieve them pre-treatment, during treatment, or post-treatment. You don't have to put all 3 of them in if you're like, you don't have to do them all 3 treatments. But if you do them, you have to indicate when you got them. Right, so maybe while you were doing something, you're doing the marching, she got a little short of breath, so you wanted to check her blood pressure or something. You would make sure that you indicated, checked vitals at mid-treatment, and here are the vital findings, right? We'd put our BP, our heart rate, BP, temp, whatever we want to put.
So we're not necessarily taking vitals every time we see a patient.
Not necessarily, unless it's required.
Okay.
So, and you'll find out this next semester with Dr. Ovreskin, when you're working with somebody that you're doing respiratory training with them, teaching them how to get their lungs cleared and stuff like that, yes, then you will take vitals every session. If this is a patient that's at risk, maybe, she's got congestive heart failure and COPD and all those other things, yeah, you're probably going to take vitals every session. But your average patient that comes into outpatient, yeah, no, John. So I know that you're a tech ed outpatient, right? I thought, if I remember correctly. Yeah. How often do you guys check your patients' vitals?
Not often.
Yeah, not often at all, right? I mean, it may be a few every now and then, but pretty rare, right? Now in the hospital, so I'll answer in a second, Christina. Good question. In the hospital, a lot of times we will either check the vitals at the beginning of the session, or I could also put, with vitals, I could put C nursing assessment or pre-TX vitals. And what that's saying is the nurse took the vitals before my treatment. And so Christina says, would we talk to the PT about the exercise that we want to add or DC for the plan? And again, that is really going to be PT dependent. For most PTs, as long as you're staying within their established plan of care, meaning if she's a total hip patient, we're just adding and removing total hip exercises. That is within our scope of practice. But there are going to be some PTs, Christina, I'm going to tell you, and I've worked with them, where any change that you make whatsoever, it could be just adding a 1 pound weight, you have to clear it with them. And that could be really, I mean, that's a pain in the butt. I'm just going to be honest about it, right? It's a pain in the butt. That's why I like working in neuro, because I can't do half this stuff. Like my flow sheets don't exist in neuro because what I do one day to the next is never the same. But yeah, so you may want to check the PT. You may say, hey, Dr. Ovreskin, hey, I want to discontinue the marching to their HEP. Is that okay? Like, yeah, sure. They're already doing it. Don't worry about it. Good job. Add another exercise for it, though, right? Because if we discontinue one, we may want to add a new one. And that may be something I may put in here. So if I say DC ankle pumps to home exercise program, add standing heel raises to treatment. So if I'm deleting one, I should want to add another. John says there are times where a patient PT doesn't reassess until after a few visits. So you would just, yeah, you maybe, it's exactly right, John. So and he made up a good point is that, maybe they achieve that short-term goal and the PT is like, hey, you know what? I'm not going to add a new goal right now. I'll add the goal in 2 visits when I reassess them. Okay, good. We've advised the PT about it. That's all we have to worry about. And my next note, I would put in my plan, discuss short-term goal situation with PT, just so that I put it on there. Diane asks, would your notes be shorter if the patient is bedridden? Yep. And I'll be telling you this, and this is from experience. If your notes are shorter, make sure they are thorough. And what I mean by that is make sure you indicate everything that you're doing with the patient. Because when you write a really short note, if somebody just comes by as an auditor and looks and that note is like 2 sentences, it's going to catch their eye more. Does that make sense? Because they're like, hey, if they only did this much, why is this note so short? Right? So that'd be one where I would indicate patient bedridden, perform the following bed exercises with patient. Sure. Your notes are always going to be shorter if the patient's bedridden. Yeah, especially, or if they're in a coma. Right? Most of the time, if I'm in a coma, I'm just doing PNF with them. So I might get 1 unit, maybe 2, if I'm going to sit them up to the edge of the bed. But again, you just want to make sure that if your notes are shorter, there's a reason why they're short. It's not that you're being lazy. All right, so I noticed one thing I did not put in this that we should have gone over with the patient. What is that? Pain level, okay, we actually have that. Okay, HEP, yeah, okay, I'll agree with you there, John. I probably should have, I don't always go over their HEP with the patient, but okay, I can put that. If I reviewed the HEP with the patient, where would I put reviewed HEP with patient? Anyone have an idea?
Assessment, maybe?
Okay, so I got an assessment. Where else might I put it? Objective, okay. So this is going to be, again, another one of those facility kind of specific. Most of the time, if I'm just reviewing the HEP, you'll see a lot of the clinicians will just go, something like that in the objective. Reviewed HEP with patient, patient indicates compliance. And that's basically saying the patient, you ask patient, did you do your exercises? Yeah, I did my exercises. Are you doing all 3 of them? Are you doing your hip slides? Blah, blah, blah. And patient's like, yep, I did all those. Okay, great. Right? That's kind of that kind of thought process on it. You could also take this, and if you maybe when you did the HEP review, the patient wasn't so compliant with the HEP. Then I might move that down here to assessment and say reviewed HEP with patient and noted only 50% compliance with HEP. I can put that in assessment or something like that. So it just kind of varies upon what happens. And then Bianca and Jason both brought up the other one, and that is hip precautions. Actually, now that I think about it, I'm thinking better through this. Reviewing the HEP would probably be better in the HEP. How much the patient recalled would be an assessment, would be better. So especially if this patient was only 50% compliant with HEP, that would be an assessment, noted 50% compliance. So yeah, technically, the HEP is more objective, but again, it's going to be a facility kind of specific thing. With total hip precautions, I'm going to recommend this. Most of the time when I review total hip precautions, the first place I put that is right at the beginning of my objective. reviewed total hip replacement precautions with patient 4 times. And, or let's say 3 times. I'm going to say 3 times. Pre-TX, during TX, post-TX. So that means I reviewed them 3 times. That doesn't indicate if they're compliant. That just indicates that I reviewed them with him. My indication for compliance would be over here in assessment. So I might put patient continues to break hip flexion, total hip replacement precaution. Despite queuing. So what this says is I've reviewed, and the reason why I put my total hip precautions right at the beginning of my objective is because that way if the patient dislocates and suddenly the nursing supervisor is coming down on you and says, you didn't review the hip precautions with these patients, blah, blah, blah. You can pull out your note. You can go right to the beginning of the O and go, here it is. I reviewed it 3 times with them. In my assessment, it indicates they continue to violate the hip flexion precaution. Right? It's just one of those that it's right front and center. And when I have stuff like that, or spinal precautions, weight-bearing precautions, I tend to put them right at the beginning of my O, just because it's easy to find them. Does that make sense? Again, your 2 main goals of your documentation. Yeah, you have to practice. You're exactly right, John. And I'm actually going to give you a homework assignment next week on SOAP notes. So don't worry, you'll have some practice. Try to be nice and ease you guys into them. The next week, you're going to have a pretty big homework assignment on them. So, well, not big, but you'll have a good bit to do. So when I started writing my SOAP notes, it would take me about 10 minutes to write a SOAP note. I'm going to be honest. It just did. Right? So, it would take me about an hour to do all my notes for the day. It has gotten faster. And again, because we have a kind of a hypothetical patient here, it's a lot harder to write a SOAP note about them because we don't have a patient. Right? So one of the homework assignments I'm going to give you is I'm going to give you a bunch of stuff that you found while you're doing the treatment. And I want you to take that bunch of garbly goop and turn it into a SOAP note. That's kind of one of the assignments I'm going to give you. So it'll have the pain levels, it'll have what exercises they did, range of motion, stuff like that. And I want you to turn around and turn that into a cohesive SOAP note. And yeah, you guys can be a little bit liberal. If you want to add some stuff in assessment, that's okay. But it's just going to be mainly to help practice and get you faster at this. Ideally, you should be able to write your SOAP note within 7 minutes. Why do you think 7 minutes? Why do you think 7 minutes is a good goal?
I'm just guessing for billing.
Yeah, for billing, right? Yeah, it's less than a billable unit. There we go, Truman, right? And the other thing is, remember, I'm going to come over here and write on this. Remember that we're going to see most patients for a 60-minute treatment session, right? In order to get 4 units, 45 is our 3 units, right? 3 units, plus another 8 minutes to get our 4th unit. So we have 4 units there. So that means we did 53 minutes of an actual treatment session with the patient. That means you have 7 minutes of float time. You should be able to get your note written in that 7-minute period. Now, I know some of you are going, there ain't no way, Mr. McKeever, I'm not there yet. No, you're not. It's okay. You will, Amanda. It will come quick. And here's the deal, is as we progress, and especially when you get to your second clinical, that's going to be one of their focuses on your second clinical, is getting you faster at doing notes. Same thing with next semester with Dr. Resk and I, is getting you faster at writing notes. For the most part, because we're in electronic health records now, I can whip out a SOAP note in about probably 2 to 3 minutes. mainly because I don't have to write all this anymore. Most of what I'm doing, you know, like, for example, most of what I'm doing on my tablet, I'm literally just going down through and clicking. So I'm not even writing anything out. I might write my assessment out, but even that, sometimes I'm just taking an assessment I had previously, carrying it forward and modifying it. Just changing what changed today versus the last session. So electronic documentation has made this a lot quicker, right? And even discharging and adding exercises with electronic documentation, there's buttons, discharge to HEP, it sends it to the HEP, and then you just add your new exercise in. So I will say the electronic documentation has made this a lot faster. And we're gonna look at electronic documentation here in a couple days. But I mean, it didn't take us that long to do this. It took us longer to talk through this than it took for me to write all that out. And again, most of that I made up. So if I actually had a treatment plan where I'm working with the patient, it probably would have been faster. You guys will do this, I promise you. By far the biggest pain in the butt in all of our treatment is documentation. It just is, because it's kind of boring, right? I don't want to sit for an hour and write my notes. From a health perspective, and when I say health, I'm talking mental health perspective. What I'm going to tell you guys is please try not to take your SOAP notes home, because I know a lot of clinicians that do this. They will work their butts off all day long. They'll work 10 hours a day. They won't do any of their SOAP notes. They take their work laptop home with them, and they go home and they sit for the next hour at home writing SOAP notes. And when they do that, that's unpaid. And not only that, but you know, I don't know how many of you guys have found this and how many have worked like places like this. But what happens? Yeah, work through lunch for notes, exactly, right? What happens when you do that, though? What does that do to your morale? Right? If you have to take work home or you can't take a lunch, doesn't it kind of destroy your morale? Like it does for me. Yeah, it makes you short-tempered, right? So you have to balance that. There is that life-work balance. And for you guys, the main thing I'm going to tell you guys for your CIs is, yeah, you're going to get faster, right? They understand that your 2-week clinical, you're not going to be fast at SOAP notes. They're going to be there a little bit with you, writing SOAP notes. They're going to be there a little after. And a lot of times the clinics will shorten the caseload. So maybe instead of your PT or PTA seeing 9 patients a day, they may only see 6. So that way they can train you a little bit better, right? And Diana, that's a good quote. So Diana says, I'm scared I don't remember anything between patients. That's where you just have to have a little kind of what I call a crib sheet or a little notebook. I carry a packet of soap, or what is called, Post-it notes with me. And I just kind of scribble as I'm doing stuff and leave little notes for myself. And then I get to the end of the day and I look at that and I go, I have no idea what I wrote there. It's a skill. It really is. And if you, I don't want to, I guess it's going to be on recording. I'll be honest, a lot of times, if you talk to a lot of clinicians, do they document everything they did? They probably forget some stuff, right? We really should be documenting after every treatment. We should be documenting as soon as we're done with that treatment, we should be doing documentation. And when I'm doing wound care, a lot of the facilities require that. They require me to document it immediately after I do wound care, because they're worried that I'm going to, exactly like Diana said, I'm not going to remember everything. So they want that documentation, that wound put in as soon as I've treated it. Number one, that also tells the doc how the wound's doing, right? He can go and look at my wound care note. No, the wound's doing good. I don't need to change anything, or I need to change something. So SOAP notes, not as hard as they look. They're just a little bit lengthy, right? Now, this is not even the hardest type of SOAP note, because this is just the basic SOAP note. There is a SOAP note that's a little bit more in depth than this, and it's called a narrative SOAP note. We're not going to do that today, but we will talk about it in another time. A narrative SOAP note, there is no S-O-A-N-P. A narrative SOAP note you write as if you're writing a story. And so when you do these exercises, like say we're doing sit to stance, in a narrative SOAP note, you have to indicate why, and I saw your note, your message, Amanda, I'm going to answer in a second. In a narrative SOAP note, we would have to say sit to stand transfers times 3, min assist times 1 from a fixed armchair to progress short-term goal 3. So in a narrative note, you have to indicate why you're doing every single thing you're doing. So every exercise has to relate back to your goals. Those notes, like stab me in the eye, please. I'm going to be honest. I hate doing narrative SOAP notes. The good news is I think we've done away with all the clinics that do narrative SOAP notes in the Valley. I think most of them have now gone to electronic documentation. I could be wrong. There may be one still out there that does narrative. I know there's one clinic that I know in Tucson that does narrative SOAP notes, and that's just the director of rehab's preference, because that director of rehab thinks that if they do narrative SOAP notes, Medicare will ignore them. Medicare ignores nobody. So there are different types of SOAP notes out there as well. And so Amanda says, my worry is, how am I going to have the time to read the previous SOAP note, figure out stretch exercise to work on? Not even sure how to progress the patient right now. Whew. That is a lot of worry. Good news is you're not a skilled clinician yet. You're not. You're not supposed to be perfect. Right? So don't totally freak out about that yet. Okay? You're not a skilled clinician. How do I do my, so if you're wondering how I do this, the one thing I do at the end of the night, once I'm done with my SOAP notes, I spend about 5 minutes looking at my patients for the next day. And that's it, 5 minutes. I don't read thoroughly through every single note that the previous clinician did. I just skim through my SOAP notes for the next day, and I look for stuff like asterisks for pain. Or I look at, oh, okay, so Mary's walking farther today. Or, Mary hadn't walked before, now she's walking. And I skim through them, or I'll skim them through them in the morning. If I'm in the hospital, I usually do it in the morning because that's when I find out who I'm treating. In the outpatient world, I usually know a day ahead who I'm treating. In the hospital, usually when you come to, when you come in the morning in the hospital and rehab department, they have a folder with your name on it, and that folder is all the patients you're seeing for the day. You usually have about 15 patients, even though you may not get to see all of them because there's usually 60 patients in the hospital, only 4 of you going by floors. So you get to see as many as you possibly can in that pile that you have. So you're not a skilled clinician. You're not supposed to know this all yet. What you should be able to do as an entry, or not even entry level, as a new coming into PTA student, Amanda, this is what I expected for like my short clinical students. I expected you to be able to open a chart and look at a SOAP note. I wanted you to be able to tell me what you might be worried about. Looking at it, oh God, this is a max assist times 2. I am going to need help with this patient. That type of a thing. I want you to be able to look at the flow sheet and just be able to do the exercises. I don't expect you to be perfect with the exercises. You're 2 weeks. It's not perfect. I expect you to be able to look at the exercises and go, oh, I've got 5 exercises to do. I want to make sure I do all 5 of them. You're not going to be progressing. You should not be progressing a patient this clinic visit. If you somehow magically, like suddenly, Oscar is just, whatever reason, he's a rock star and he's got it all down pat and he's, ahead of everyone in the classroom and he just happens to be really super duper smart. And, he's just doing great. Maybe then I might ask him to, how would you progress this or how would you regress this as a clinician? But for the most part, if John's coming to me as a student, I'm expecting to be able to hand him a flow sheet and say, let's go do these exercises. And is John going to know all the exercises? No, he's not. Yep, there's an excellent idea. So John says, would you recommend looking at the previous note while the patient's warming up? Sure. And you know what I do a lot of times when I'm doing that, John, is I talk to the patient at the previous note. So while they're on the treadmill kind of warming up or they're on a hot pack, I'd be like, so last time you did a bunch of back extension exercises with Jimmy, How'd those go for you? Right? Or I'm like, oh, hey, it looks like you didn't like the E-stim last time. What didn't you like about it? Right? So that just kind of gets me in my mindset. Because you do have that little bit of time on the warm-up. Now, if you're in the hospital, the warm-up time is while you're cleaning up the room and getting ready for treatment. So you're kind of going, oh, so last time when you were working with, and you're moving trays out of the way and kind of getting the bed set up, like, oh, you know, that type of stuff. And for those of you going inpatient, I'm going to actually get out of share screen here real quick. For those of you going inpatient, a lot of the stuff we're talking about, looking over flow sheets, stuff like that, there may not be a flow sheet in the inpatient world. Does anyone know what the majority of what you do in the inpatient world is? More than even exercise.
No, sit hands.
Right. Two of you have talked over each other, so I got, yeah. Yeah. Gait. Bianca's exactly right. Gait and transfers. And sit to stands. Yep. So transfers. Because I'm going to be 100% honest. In the inpatient world, I get about 23 minutes with every patient. 23 minutes doesn't give me a time to, we're all in the inpatient world, exactly. I don't get enough time. Literally, at that point, I am inpatient. Right? In the inpatient world, I don't have enough time to do 50 exercises with the patient, unless I'm like in a neurospecialty unit or something like that, and then I get some extra time. But for the most part, what I'm doing with my inpatient patients is getting them out of bed, getting them up, walking them down the hallway, and getting them sitting out in a chair. That's most of what I do in the hospital. I joke that in the hospital, PT stands for patient transfers, because that's a lot of what we do. We get them out of bed and we put them back to bed, because we just don't have a ton of time. You know, when I'm at, like, if I'm at TMC or I'm at UMC here in town or something like that, I don't get a lot of time with my patients. So it's not like I could spend 1,000 hours working with my patients and doing that. Does that make sense? And again, we'll get you better, and don't totally freak out. I can literally feel Amanda's tension coming through the computer at me here. I just can feel it. Look at those eyes, right? You know, here's the deal. If you've ever played with a niece, a nephew, a cousin, anything like that, you can do therapy. It's not all that. I mean, they're just giant kids. So an inpatient setting, it depends. Most times it's about 23 minutes is what I get. Then Brooke asked, you get more time in a sniff. Again, that depends. In a sniff, so it's funny. In the inpatient world, like in the hospital, the problem is there are just so many patients, you don't have a ton of time with each patient. Most times, right now it's a little better because census, which is the amount of people in the hospital, is low because of COVID, right? But once it gets banging back up and forth, it's nothing to have 20 patients per clinician. And you're like, I've got to figure out how to see all 20 of these patients. It's not going to happen. In the sniff, you have what's called rugs you have to meet. And it's not like you go, hi, Mr. Rug, how are you doing? No. A rug is a billable unit. So some patients, they'll have 45 minutes assigned to them on rugs. Some they'll only have 15. And you just have to meet whatever their rugs are. And you have to treat them. And if they only have a 15-minute rug, you can only treat them for 15 minutes. You can't treat, if you treat them for over 15 minutes, it's unbillable. It's really, yeah, Jason, I saw Jason's face. It's like stupid, right? It is. And we're going to talk about how that plays into patient's care. It is mainly gait training, or the other thing I do a lot in sniffs is a lot of ADL type stuff. So getting them to the bathroom and back, right? Helping them. And again, for those of you, how many of you guys want to wipe a butt? All of you should say yes. You're going to have to. That's just the way it is. In the inpatient and the sniff world, you're not always going to have a nursing assistant there to help you change the brief, to help transfer a patient. And here's the deal. It's functional. If I can get them to the bathroom, that's a walk. I'm happy for that. Yeah, I mean, I have to wipe a butt a little bit, but I can also work on them doing self-cleaning. That's an ADL activity, right? So yeah, I do a lot of ADLs. Oh, lol. Yeah, exactly. And that's the good idea right there, Brooke, as long as you're helping. And what I find in the hospital is if I help with those ADLs, I help with going to the toileting, I help with changing a brief. That's what Cindy said, don't make it weird, right? I help those type activities. When I go to the next room and I need a hand, and I go to the CNA and say, hey, man, this guy's 500 pounds. I could use an extra set of hands real quick. Can you come in with me just to make sure he doesn't fall down on me? The CNA remembers that you changed that brief in the next room and they're in there with you. You know, what the CNAs also remember is if Jason walks into a room and he's like, oh, somebody left a dump. Hey, CNA, they need their brief changed, right? And he does that. The CNAs remember that. And the next time he's sitting there and he's by himself and he's got the patient halfway between the chair and he needs a hand, they walk by the room going, right? And it just happens. Yeah, that's why I said it, Jason. I knew that. Right? And you can attest to that, right? When you get help, you're more likely to help somebody else. And I found that I was a CNA too. I found that being a CNA for a short period of time, and it was a short period of time, honestly, really made me kind of humble as to helping everyone else, because honestly, literally, CNAs deal with a lot of literal shit. I'm just saying. But yeah, so don't make it weird. Just treat your patient. Don't freak out. Your first clinical is not special. You're not going to be super duper rock stars. I mean, Stephanie may be, but everyone's going to make mistakes. I screwed up on my, you know what I remember in my very first clinical is I screwed up. I stood a patient up that the chart literally said is, like the chart, I'm not joking, the previous note says, patient is royally incontinent. That was the previous note. And I didn't read that. I'm like, what is royal? I don't know what this is, whatever. I stood them up and literally, I'm not joking, they hit the wall from about 5 feet away. It was like explosive wall diarrhea. Great. I should have read that note a little bit clearer. It happens. Mistakes were made, right? You just deal with your mistakes. I've treated the wrong side before, right? I've never treated the wrong patient. I will say that, knock on wood on that. I've never treated the wrong patient because I always check my bracelets. I always make sure I'm right with the right patient, but I've treated the wrong side. I've done the wrong modality, right? I thought I was doing laser and it was actually supposed to be doing ultrasound. I'm not proud of it, but I've made mistakes. I've done the wrong exercises. It says I'm supposed to be doing bridging and for whatever reason I'm doing planks because my brain just for whatever reason completely farted at that point. It happens. Don't worry, man. I know your brain is kind of fried at this point. You'll be okay. I promise you. Your clinicians will be there to hold your hand the whole way and say, come with me to the promised land of money. That's the main idea. Fake it until you make it. You're exactly right, Diana. Honestly. Nope. There's no crying in therapy. Isn't that what Tom Hanks said? Or wait, no, that was baseball. Yeah, anyway, and honestly, Amanda, there have been days, and I'm going to be admit it, even as a clinician, there have been days where I've gone home, and I don't typically cry, but there have been days where I've come home, and that heavy bag that I have hanging out back has taken a severe beating because I was just completely frustrated with my day. One of my friends just texted me, the hand therapist I was working with, texted me and said, she has 15 evals tomorrow for hand therapy, 15 in an outpatient world. 5 of those require splints. Can you imagine trying to get that done in a day? Right? No. And so she's like, I don't know what they're doing. I'm not super person. Right? And she was like, I feel like I want to cry. I'm like, go out for a walk, go out for a run, get it out of you. It happens. We all get frustrated. You all get frustrated with me. All right. Oh God, it's 55 after. I ran too long. We'll talk tomorrow. I don't want to run any longer because I don't want to keep you guys any longer. We'll talk tomorrow about the midterm. First thing. How's that sound? And then we'll get into kinese. All right, guys. Yeah, time to get a therapist. Or what I say is it's just time for a shower and a box of wine in the shower while you're there. I mean, box wine is great, right? Just joking. All right, I'm going to stop.